Imagine this. You're a surgeon, maybe anywhere in the world, really, and a patient comes in with, well, a problem that just doesn't seem to fit the usual boxes.
Mm.
It could be a mass that feels different, or maybe an infection that just laughs off your standard antibiotics, or, symptoms that eerily mimic common conditions, maybe even cancer.
Right. It's not just a theoretical thing anymore.
Exactly. This isn't just some thought experiment for specialists in, faraway places. It's a growing reality in our incredibly connected world. Because of global travel, conditions once thought of as strictly tropical are now showing up unexpectedly.
And often landing right on a surgical team's doorstep, sometimes as pretty complex emergencies. It really does highlight how those geographical boundaries are blurring when it comes to disease.
Totally. What might seem exotic one day could be, well, right here the next. And that is precisely why we're dedicating this deep dive. Using these excellent sources you provided specifically, these detailed excerpts from a major surgical textbook, to absolutely immerse ourselves, really get deep into a critically important and often challenging area of surgery: tropical infections and infestations.
Yeah, and our mission here isn't just, a quick skim or a general overview. We are going deep, really deep.
We mean it.
We're going to unpack every key piece of information in this text. We want to understand the intricate pathology, the clinical features, which, let's face it, can be deceptive, master the investigations, and really grasp the specific management strategies.
Think of it like this. We're aiming to step into the shoes of the elite professionals who actually manage these tough conditions day in, day out. We're here to dissect this material, understand all the nuances, and really master it. So that you, listening, can approach these rare but absolutely critical cases with the kind of confidence and knowledge that comes from deep understanding. We'll be your guides through this.
And we'll make sure we cover everything the text lays out, providing context and, highlighting the most crucial clinical and surgical implications.
Okay, great. Let's jump right in and start this deep dive. Our first stop is a condition that can cause some serious surgical headaches. It's called amoebiasis, caused by the parasite Entamoeba histolytica.
Right. This is a really big issue, particularly common in places like the Indian subcontinent, Africa, and parts of Central and South America. Its spread is fundamentally linked to substandard hygiene via the fecal oral route.
Okay.
What's critical to appreciate right up front is just how prevalent it is in endemic areas. The source says up to 10% in Southeast Asia. But also, and this is key, a huge number of carriers are completely asymptomatic. They feel fine.
But they can still develop serious problems, right?
Exactly. The potential for severe complications like liver abscesses is always there, with incidence rates up to, I think the figure was 21 per 100,000 in some populations.
Wow. Okay, let's unpack the journey this parasite takes, because understanding the pathology, that's really key to getting the clinical picture.
Yeah.
So you ingest the cysts. They hatch in the small bowel into these active forms. They're called trophozoites.
Oh,
And then they travel down to the colon.
okay.
And here's where the trouble starts in the gut itself. They invade the submucosa, creating these characteristic flask-shaped ulcers.
Flask-shaped, right. I remember that description.
Yeah, these ulcers are significant in themselves, but it's often their next move that brings patients to the surgeon.
Right, they can either form new cysts, which get passed on, perpetuating the cycle, or, crucially, they can get into the portal circulation, straight shot to the liver.
Exactly. Once they're trapped in the liver, they multiply, especially in the portal triads. And using these proteolytic enzymes they have, they cause focal tissue damage. Liquefactive necrosis is the term, basically dissolving liver tissue.
And these areas merge. Yeah, these necrotic areas merge together to form the actual abscess cavity. The source also mentions amoebic hepatitis for sort of microscopic liver inflammation without a big abscess, but importantly, the medical treatment is actually the same for both.
Got it. So the liver abscess is the major surgical thing here. Where do we typically find them? Is there a preferred spot?
Yeah, the source highlights a really strong preference for the right lobe. About 80% of cases, maybe 10% in the left, and the rest are multiple.
80% in the right lobe. Why is that, do we think?
Well, the theory, as mentioned, relates to blood flow dynamics, potentially the more direct path of blood from the superior mesenteric vein heading into the right lobe. And these abscesses often form quite high up near the diaphragm.
Ah, which explains why patients might present with lung symptoms, right? Like a cough or hiccups.
Precisely, that diaphragmatic irritation.
And the fluid inside. The textbook gives that classic description.
Yes, the classic anchovy sauce appearance, typically chocolate-colored, and importantly, odorless. It's usually sterile unless, and this is a key point, there's a secondary bacterial infection.
Then it smells like pus.
Then it would smell like pus, exactly. Interestingly, actually finding the trophozoites themselves within the abscess wall happens only in a minority of cases.
And the biggest surgical emergency associated with these has to be rupture.
Absolutely. An untreated abscess can rupture into the peritoneal cavity, the pleural cavity, or even, disastrously, the pericardial cavity. Major life-threatening complications.
Now, the source also mentions a chronic intestinal complication that sounds like a major diagnostic pitfall for surgeons. The amoeboma.
This is a critical point for, real mastery of this topic.
Yeah.
An amoeboma is a chronic granulomatous lesion, basically a lump of inflammatory tissue most commonly found in the cecum.
Okay.
It typically shows up in settings of long-standing infection, maybe infection that's been inadequately treated, like if someone in a resource-poor country has been self-medicating on and off.
And the huge pitfall. It can look exactly like
Cancer, exactly like carcinoma, specifically a caecal cancer. This is where thinking like an expert really means having that high index of suspicion baked into your approach.
So given this potential confusion, how do we even begin to differentiate them clinically? What clues does the source give?
Well, the source guides us. Suspect amoeboma in a patient from an endemic area presenting with general ill health, maybe a fever, a palpable mass in the right iliac fossa, and crucially, a history of blood-stained mucoid diarrhea.
That history seems key.
It is, and here's a subtle distinction mention. Altered bowel habit, while really common in left-sided colon cancers, is actually less typical for right-sided ones, like caecal cancer. So the specific history of bloody diarrhea points more towards amoebiasis. However, both conditions can present with iron deficiency anemia, though maybe for different reasons, malnutrition in amoeboma versus chronic blood loss in cancer.
That travel history or history of residence, it just seems absolutely paramount here. It's a thing that might make you think outside the standard box.
Non-negotiable, really.
What about investigations? What do we rely on?
Routine bloods will often show those general signs of chronic infection, anemia, maybe a raised white cell count, leukocytosis, elevated inflammatory markers like ESR and CRP, often low albumin, and if the liver is involved, deranged liver function tests, especially a raised alkaline phosphatase.
Okay, and specific tests for the parasite itself.
Serology looking for antibodies is very useful, especially in non-endemic areas. Tests like IHA or ELISA have high sensitivity there. However, and this is a key distinction for mastery, in endemic areas, many people have antibodies from past exposure, so a positive test is much less specific for current active infection.
Right, so in London or New York, positive serology is a strong flag. In Mumbai or Lagos may be less definitive on its own.
Exactly. In those settings, combining serology with direct parasite detection like antigen tests or DNA PCR is much better, but the source rightly notes that cost and accessibility really limit these advanced tests in many developing nations.
Got it. What about imaging? How do we see these things?
For the liver abscess, ultrasound and CT are definitely the go-to tools. Ultrasound is accurate for seeing the lesion typically hypoechoic or anechoic, often with ill-defined borders, and it's great for guiding aspiration if needed. CT is valuable if the diagnosis is still uncertain, or to look for associated things like a raised diaphragm or a pleural effusion.
And for the bowel, especially that amoeboma versus cancer issue.
Well, endoscopy is crucial. It can show these discrete, sort of punched-out ulcers, often covered in exudate, with normal-looking mucosa in between. And again, there's often a predilection for the cecum and ascending colon.
Okay, let's go back to that really tricky amoeboma versus cancer challenge. If imaging, maybe a barium enema showing that apple core deformity or the colonoscopy reveals a mass that looks suspicious for carcinoma, what's the expert approach outlined?
Right. This is vital. Colonoscopy with biopsy is absolutely mandatory. You simply cannot reliably distinguish an amoeboma from a carcinoma just by looking at it radiologically or endoscopically. The strategy outlined is critical. Start vigorous medical treatment for amoebiasis first.
Treat first, then see.
Exactly. If it is an amoeboma, it should completely regress, disappear, usually within 3-4 weeks of proper treatment. If the symptoms persist after a full course of medication, or if that mass doesn't completely go away on follow-up imaging or scope, then you must definitively exclude colonic carcinoma.
So follow-up is essential.
Absolutely. The source even gives this really important warning. Sometimes a dormant cancer might only become clinically obvious after the amoebic infection has been treated. And it's even possible for an amoeboma and a cancer to coexist in the same area. So that follow-up colonoscopy after treatment is non-negotiable if a mass was initially suspected.
That's a powerful lesson in diligence. Don't let the obvious infection blind you to a potential underlying malignancy.
Precisely. It requires real diligence in understanding these nuances. So, just to condense the key diagnosis points from the source, suspect it with bloody mucoid diarrhea plus endemic area travel or residence, or with upper abdominal pain, fever, cough, malaise, suggesting liver involvement, or a chronic right iliac fossa mass where excluding cancer is top priority. Sigmoidoscopy might show typical ulcers. Serology is good outside endemic areas. US and CT are the imaging choices, especially for liver abscesses.
And treatment. Medical treatment seems to be the cornerstone here.
Yes, it's generally very effective. Metronidazole or tinidazole are first line for the invasive disease, followed by a luminal agent like diloxanide furoate. That second drug is important to clear any remaining parasites just hanging out in the gut lumen to prevent relapse or continued transmission.
Okay, so when does the surgeon actually get involved, beyond maybe helping with the initial diagnosis?
For liver abscesses, aspiration, or maybe inserting a pigtail catheter for continuous drainage is indicated for really large abscesses, especially if they're in the left lobe, given that higher risk of rupture into the peritoneum or pericardium.
Okay, left lobe is higher risk.
Yes. Drainage is also used if the patient isn't improving clinically on intravenous metronidazole alone. Draining the pus can actually help the antibiotics penetrate better into the abscess cavity.
So surgical intervention for abscesses is mainly for complications, or large ones, or those not responding to drugs.
Exactly that. Open surgery is primarily reserved for those life-threatening complications like rupture into the peritoneal, pleural, or pericardial cavity. That becomes a surgical emergency. Resuscitation, urgent drainage, thorough lavage or washout of the contaminated cavity, and of course, continuing vigorous medical treatment.
What about intestinal complications?
Intestinal complications like severe hemorrhage or toxic megacolon are rare, thankfully, but they are also surgical emergencies. They're managed similarly to other causes of toxic megacolon: aggressive resuscitation, bowel resection, usually with exteriorization like creating a terminal ileostomy and closing off the rectal stump and intensive supportive care afterwards.
And the amoeboma, if it doesn't disappear after medical treatment.
Then colonic resection is indicated, especially if cancer couldn't be definitively ruled out earlier.
So wrapping up amoebiasis, the critical surgical takeaway for you, the listener, is really, this condition is no longer geographically isolated. Its insidious symptoms, its ability to perfectly mimic common, potentially deadly conditions like peachal cancer. It means a detailed travel history and maintaining a high index of suspicion are absolutely non-negotiable for surgical professionals anywhere. Mastery here means knowing when to even think of this tropical diagnosis and, crucially, how to navigate that diagnostic overlap with malignancy.
It's a perfect illustration of how global connectivity really impacts day-to-day surgical practice.
All right, let's shift gears quite dramatically now to a parasite that affects a truly massive chunk of the world's population. The roundworm, Ascaris lumbricoides.
Yeah, this is the commonest intestinal nematode globally. It affects roughly a quarter of humanity, which is just staggering. It's a major cause of morbidity, especially in children, with different symptoms depending on its life stage and, well, where it happens to be in the body at any given time.
And its life cycle is quite the journey through the host, isn't it?
It really is. It starts with fertilized eggs being passed in feces. In the right conditions, warm, humid soil, often found in tropical areas with poor sanitation, these eggs become infective over about 3 wipes. Ingestion of these infective eggs, typically via fecal oral contamination, is how humans get infected.
So you eat the egg, it hatches in the jejunum into a larva, and then the larvae embark on this rather circuitous route.
Precisely. They penetrate the gut wall, get into the portal system or the lymphatics, travel first to the liver, then into the systemic circulation to reach the lungs.
The lungs.
Yes, the lungs. In the lungs, they mature over about 2 weeks, then break into the alveoli, get coughed up, and then swallowed again.
Ah, okay. Bringing them back to the small intestine, where they finally mature into adult worms.
That's the one. And these adult worms can be surprisingly large. The source says up to 45 centimeters long. A mature female can produce just countless eggs daily, which are then passed in feces, restarting the whole cycle.
Now, surgically speaking, it's the adult worms that can cause serious complications, right? Their migration.
They certainly can. After being swallowed back down from the lungs, the young worms or even adult worms can migrate. Critically, they can wander into the common bile duct or the pancreatic duct,
leading
to biliary obstruction, ascending cholangitis, obstructive jaundice, or acute pancreatitis. The eggs themselves, if they get into the biliary tract, can even serve as a nidus, a starting point for gallstone formation later on.
And the most dramatic surgical presentation often involves a large number of worms causing a blockage.
A worm bolus, yes. Essentially, a tangled mass of adult worms, typically accumulating in the narrow lumen of the terminal ileum, can cause acute small intestinal obstruction. This is a real surgical emergency, particularly seen in children in endemic areas. Very rarely, the sheer pressure exerted by a large bolus can cause ischemic necrosis, lack of blood supply to the bowel wall, leading to perforation.
Beyond these acute emergencies, what about symptoms during the different stages? You mentioned the lungs.
Right, that larval stage migrating through the lungs can cause pulmonary symptoms. A dry cough, maybe chest pain, shortness of breath, fever. This collection of symptoms is known as Loeffler syndrome, and it's often associated with eosinophilia, a high level of eosinophils in the blood.
And the adult worms just living in the small intestine.
They can cause vague abdominal pain. In children, particularly with heavy worm burdens, they can contribute significantly to malnutrition and failure to thrive simply by consuming nutrients meant for the host.
So putting it all together, a patient from, or recently returned from, a tropical area presenting with any of these symptoms, pulmonary, general GI discomfort, or specific hepatobiliary or pancreatic problems, should definitely trigger suspicion for ascariasis.
Absolutely. The source really emphasizes maintaining that high index of suspicion.
How do we actually confirm the diagnosis then?
Well, eosinophilia on blood tests is a common clue. The standard diagnostic test is stool examination for the characteristic over the eggs. During that pulmonary phase, sputum or maybe bronchoscopic washings might show Charcot-Leyden crystals or even the larvae themselves. And a chest x-ray during Loeffler syndrome might show transient, kind of fluffy exudates.
Imaging sounds like it plays a vital role, especially when complications like obstruction or duct involvement are suspected.
Oh, definitely. A barium meal and follow-through can be quite revealing. It might show the worms free in the small bowel lumen. Sometimes you can even see the barium outlining their own digestive tracts. Or it can clearly show a tightly packed bolus of worms causing obstruction, usually down in the ileum.
And ultrasound.
Ultrasound is excellent for visualizing worms directly within the gallbladder, the common bile duct, or the pancreatic duct when patients present with biliary or pancreatic symptoms. MRCP can also clearly show an adult worm causing obstruction in the common bile duct.
What about for acute intestinal obstruction?
A plain abdominal x-ray might show the dilated small bowel loops, and sometimes you can actually see the tubular structures of the worms within them. Contrast-enhanced CT can further clarify this, showing them as these distinct curvilinear structures within the bowel.
Okay, so summarizing the pathogenesis and diagnosis points from the source. It's the commonest intestinal nematode, prevalent in hot, humid areas, poor sanitation. Larvae cause pulmonary symptoms. Adults cause GI, biliary, or pancreatic issues. Distal ileal obstruction from a worm bolus is a key surgical emergency. Cholangitis or jaundice from CBD infestation. Pancreatitis from pancreatic duct infestation. Perforation is rare. Diagnosis relies on barium studies, ultrasound showing worms in ducts, or plain X-ray CT showing them in obstructed bowel.
Right. Now, when it comes to treatment, the approach really differs based on the stage and the severity.
Medical treatment with anthelmintics is primary for the intestinal phase, I assume.
Yes, using drugs to kill the worms.
Yeah.
However, and this is a really critical point for surgeons to grasp, the source explicitly warns that the rapid death of a large worm burden after giving anthelmintics can actually precipitate acute intestinal obstruction.
Wow, okay. The treatment itself can potentially cause a surgical emergency.
Exactly, because all the dead or dying worms suddenly form this dense, immobile bolus.
So how do you manage an obstruction when it happens, or if you suspect a huge worm load?
Well, for intermittent or subacute obstruction, the source suggests a trial of conservative management is often attempted first. That means 4V fluids, nasogastric suction, and, interestingly, hypertonic saline enemas.
Saline enemas, how do they help?
The thinking outlined is that the hypertonic saline helps to physically disentangle the worm bolus down in the ileum and also increases gut motility, hopefully encouraging the worms to pass naturally into the colon where the lumen is wider.
Fascinating. And surgery is reserved for specific situations then?
Correct. Surgery is indicated for intestinal obstruction that doesn't resolve with that conservative management, or if there's any suspicion of complications like perforation or gangrene.
What's done at surgery for a worm bolus?
At laparotomy for an ileal worm bolus, the preferred approach, if possible, is to gently milk the bolus of worms proximally or distally, ideally through the ileocecal valve into the cecum and colon. Postoperatively, saline enemas might still help clear them.
And if milking isn't possible, there are complications?
Well, for complications like strictures, gangrenous bowel, or perforation, then resection of the affected segment and anastomosis are necessary. If the bowel wall itself is healthy but just full of worms, sometimes an enterotomy, a small surgical incision in the bowel wall, can be made to manually remove the worms.
What if there's a perforation and worms are actually free in the peritoneal cavity? That sounds messy.
It is, and the source advises that in such a scenario, it's generally safer to bring the perforated segment out as an ileostomy rather than attempting a primary anastomosis. The risk of anastomotic breakdown is just too high with residual worms or significant contamination.
Makes sense.
It's also noted that sometimes you find ascariasis incidentally, like during surgery for suspected appendicitis, or maybe a typhoid perforation, or even a TB stricture. In those cases, you just treat the primary pathology you went in for and manage the ascariasis medically afterwards.
And for those worms causing biliary or pancreatic obstruction?
Endoscopic removal via ERCP is the initial treatment of choice. If ERCP fails or isn't possible, then laparoscopic or open exploration of the common bile duct is required, often combined with a cholecystectomy. But regardless of the surgical intervention, a full course of antiparasitic treatment is absolutely essential postoperatively.
Okay, quick diagnosis and management summary from the source boxes. Barium meal follow-through shows worms. Ultrasound shows them in bile pancreatic ducts. Plain X-ray CT shows them as tubular curvilinear and obstructed bowel. Conservative management with anthelminthics is first line, even sometimes in obstruction, but be cautious about precipitating a bolus. Surgery is the last resort for acute abdomen complications, with various options: milking the bolus, enterotomy, resection, or exteriorization, depending on the findings.
Right, and for surgical mastery here, I think recognizing that complex migratory life cycle, understanding how it presents so differently at different stages, and crucially, knowing that treating the worms medically can paradoxically create a surgical emergency, those are really the critical points that distinguish expert knowledge.
Absolutely fascinating and slightly terrifying.
Yeah.
Okay, moving from roundworms now to flukes, and specifically their impact on the liver and bile ducts. Let's explore Asiatic cholangiohepatitis.
Yes, also known as Oriental cholangiohepatitis. This condition is primarily caused by liver flukes, most commonly Clonorchis sinensis, but also sometimes Opus thorsius species or Fasciola hepatica. It's highly endemic in tropical Southeast Asia, particularly in areas near seaports and river estuaries, environments linked to its life cycle.
Which involves intermediate hosts, right?
Correct. The cycle involves snails as the first intermediate host, and then freshwater fish, crabs, or crayfish as the second. Humans and other fish-eating mammals become the definitive hosts by ingesting raw or improperly cooked infected intermediate hosts containing the fluke larva.
So the adult worm ends up living where exactly? And causing what kind of problems?
The adult worm matures and takes up residence within the intrahepatic biliary radicals, the small bile ducts inside the liver. And they can live there for years, causing chronic irritation and inflammation.
Leading to significant pathological changes over time.
Yes, exactly. This chronic presence leads to dilatation of the intrahepatic bile ducts, hyperplasia of the epithelial lining, an increase in the cells lining the ducts, and quite extensive periductal fibrosis scarring around the ducts.
And the major, really serious long-term concern linked to these chronic changes is?
Cholangiocarcinoma, bile duct cancer. These chronic inflammatory and hyperplastic changes in the bile ducts can lead to dysplasia precancerous changes and significantly increase the risk of developing cholangiocarcinoma later in life. This link between a chronic parasitic infection and subsequent malignancy is a really crucial takeaway.
The parasites also seem to directly cause problems with bile composition and stone formation, according to the source.
They do. The presence of eggs or even dead worms within the bile ducts acts as a nidus, a focal point for stone formation. What's quite distinctive about this condition is the predisposition for intrahepatic stone formation stones forming within the small ducts inside the liver itself.
Why intrahepatic?
It's thought to be partly because the parasite induces the liver to produce bile that's particularly rich in mucin, which contributes to stone development. And these dilated, damaged intrahepatic ducts are also prone to recurrent episodes of ascending cholangitis, bacterial infections spreading up the bile ducts, liver abscess formation, and general hepatitis or liver inflammation.
How does a patient typically present? Is it always obviously symptomatic?
Not necessarily, no. It can actually remain dormant and completely asymptomatic for years, sometimes only being discovered incidentally if imaging is done for another reason. When it does become active or symptomatic, the initial features can be quite nonspecific, maybe just fever, malaise, anorexia, or some upper abdominal discomfort.
And a full picture.
The full clinical picture, particularly when complications like stones or infection develop, includes symptoms like fever with rigors, shaking chills, which strongly suggests ascending cholangitis. Obstructive jaundice can occur if stones block the major bile ducts. Biliary colic, that typical severe pain from gallstones and pruritus, itching, are also common with stones. Acute pancreatitis is also possible if a worm happens to obstruct the pancreatic duct opening.
So again, that theme, a patient from an endemic area presenting with biliary type symptoms, this should be high on the differential diagnosis list.
Absolutely, especially if they present in a non-endemic area where it might not be front of mind for clinicians. Lab tests in active cases will typically show abnormal liver function tests, often reflecting the obstruction or ongoing infection.
How do we make a definitive diagnosis in these cases?
Well, the definitive parasitological diagnosis is made by actually finding the fluke eggs or sometimes adult worms in the patient's stool, or perhaps in a duodenal aspirate obtained during endoscopy. Imaging, however, is also crucial.
What does imaging show?
Ultrasound often shows a quite characteristic pattern. There's usually uniform dilatation of the small peripheral intrahepatic ducts, often with minimal dilatation of the larger common ducts, unless, of course, there are significant stones in the common duct causing blockage there. The walls of the intrahepatic ducts often appear thickened and echogenic, bright on ultrasound. You might also see non-shadowing echogenic foci within the ducts, which could represent worms or clumps of eggs. ERCP can directly visualize the ducts, confirm the presence of worms or stones, and assess the overall extent of the disease.
Okay, let's summarize the pathogenesis and diagnosis points from the source box. Occurs in far eastern tropical zones caused by those specific parasites. It leads to bile duct hyperplasia, dilatation of the intrahepatic ducts, and stone formation, often intrahepatic. Crucially, it increases the risk of cholangiocarcinoma. Can be dormant, but active disease presents with biliary symptoms and systemic illness. Stool examination for eggs is diagnostic. Ultrasound and ERCP are the key imaging modalities.
Right, and treatment involves both medical and surgical strategies.
What are the medical options available?
Anthelminthic drugs like praziquantel or albendazole are used to kill the flukes. These can be curative, especially if the disease is caught in its early stages before extensive damage or stone formation has occurred.
And the surgical challenge primarily revolves around
managing the stones. The stones can be present not only in the gallbladder and the common bile duct, as in typical gallstone disease, but also extensively within those dilated intrahepatic duct. Standard surgical treatment, therefore, typically involves not just cholecystectomy, gallbladder removal, but also thorough exploration of the common bile duct.
And the source specifically highlights something about the CBD exploration.
Yes, the need for repeated washouts during the CBD exploration. This is to clear out not just discrete stones, but also the associated debris, sludge, and biliary mud that often accumulate in these cases due to the chronic infection and altered bile.
And because recurrence is a big issue, simple closure of the CBD might not be enough. Specific bypass strategies are often needed.
That's exactly right. Because of the chronic nature of the condition and the high likelihood of recurrent stone formation, especially intrahepatic stones, simply exploring and closing the CBD might lead to future problems. Therefore, following stone clearance, a biliary enteric bypass, creating a new drainage path for bile into the intestine, is often performed. A choledochoduodenostomy connecting the CBD directly to the duodenum is one option.
But the source mentions another preference.
Yes, it notes that some surgeons prefer a choledochoduodenostomy connecting the CBD to a Roux-en-Y loop of jejunum. The potential advantage mentioned for the Roux loop configuration is that it can sometimes be brought up to the abdominal wall as an access loop.
An access loop? For what?
This allows for future endoscopic or interventional radiological procedures like passing a scope or catheter through the loop to access the biliary tree and clear recurrent stones without needing another major open surgery down the line. It's a strategy tailored to the long-term, potentially relapsing course of this disease.
That's a very specific surgical approach, thinking ahead about future problems. The source also touches on public health implications.
Yes, it highlights the importance of public health measures, particularly screening migrants from endemic areas using hepatobiliary ultrasound. The idea is that diagnosing and treating the subclinical asymptomatic form through screening can prevent the progression to severe disease and, importantly, potentially eliminate that long-term risk of developing cholangiocarcinoma.
Okay, treatment summary from the source box. Medical treatment, praziquantel albendazole, can be curative early on. Surgical intervention includes cholecystectomy, thorough CBD exploration with washouts, and often a biliary enteric bypass. Prevention efforts should include screening migrants with hepatobiliary ultrasound.
And the crucial takeaway here, I think, distinguishing that expert understanding, is really appreciating the dual threat. The immediate problems caused by the parasites, the stones, the recurrent infections, combined with that significant long-term risk of cancer development. And surgically, understanding the specific procedures needed to manage recurrent, often intrahepatic stone formation, especially the rationale behind creating an access loop for potential future interventions, is vital for mastering the management of this condition.
All right, let's move on to a disease perhaps most famously known for causing profound physical disability, filariasis.
Yes, this condition is mainly caused by the nematode Wuchereria bancrofti, which is transmitted by mosquitoes. While other related species like Brugia malae and Brugia timori can cause similar disease, accounting for maybe 10% of cases, W. bancrofti is responsible for the vast majority. It affects a huge number of people, over 120 million worldwide, with a significant concentration about 2/3 in India, China, and Indonesia.
And its impact is significant.
Hugely significant. The World Health Organization recognizes it as the second most common cause of long-term disability globally, second only to leprosy.
So a mosquito bite transmits the larvae. They mature into adult worms over about a year. Where do these adult worms actually set up shop in the body?
They colonize the lymphatic system.
Ah, the lymphatics. And it's this chronic infestation of the lymphatics that leads to the really devastating consequences we associate with filariasis.
Exactly. The source notes that males are often more affected, possibly due to cultural factors related to clothing coverage, making them perhaps more vulnerable to mosquito bites. The early acute presentation often involves episodic fever, lymphadenitis, inflammation of the lymph nodes, and lymphangitis, inflammation of the lymphatic vessels themselves. Occasionally, you can even feel the adult worms as little subcutaneous nodules.
But the image most people have is of the chronic manifestation, developing over years of repeated acute attacks, right?
Yes, that's the classic picture. The adult worms living in the lymphatics cause chronic obstruction. This leads to massive edema swelling, particularly affecting the lower limbs. The obstruction of the cutaneous lymphatics also causes the overlying skin to thicken and develop this rough, pitted appearance, which is described as peau d'orange, or orange peel skin. This skin thickening further exacerbates the swelling.
And secondary infections are common.
Very common. Secondary bacterial infections, often streptococcal, frequently occur in the swollen, compromised limbs. These lead to recurrent episodes of acute lymphangitis, which in turn cause more fibrosis and damage to the lymph channels.
Creating a vicious cycle that ultimately results in
Elephantiasis, that gross, disfiguring swelling of the limb, usually the leg, accompanied by marked thickening of the skin and subcutaneous tissues. While it commonly affects the lower limbs, the source highlights that bilateral lower limb filariasis is often accompanied by elephantiasis of the scrotum and penis as well.
and hydroceles are common too.
Yes, an underlying hydrocele, fluid collection around the testes, is frequently seen alongside scrotal filariasis, particularly in the earlier stages. In some cases, the lymphatic damage can be so extensive that it leads to chyluria, lymphatic fluid leaking into the urine, or chylocystitis, lymphatic fluid accumulating in the abdominal cavity. There's also a milder respiratory form mentioned called tropical pulmonary eosinophilia.
In advanced cases, the diagnosis sounds like it must be clinically obvious.
Oh, it is. In a full-blown case of elephantiasis, the physical deformity is absolutely unmistakable, making detailed investigations almost superficial for the basic diagnosis. However, blood tests often show eosinophilia, reflecting the parasitic infection.
How do you confirm the parasite is there?
Finding the microfilaria at the larval stage in a peripheral blood smear is diagnostic. However, a key point is that they often exhibit nocturnal periodicity, meaning they're only detectable in blood samples taken at night. So a daytime blood smear might be negative. Microfilaria can also sometimes be found in chylous urine, acidic fluid, or hydrocele fluid if those complications are present.
Okay, summary points from the source box. Caused by W. bancrofti, mosquito vector. Affects the lymphatics, causing gross limb swelling, elephantiasis. Diagnosis involves eosinophilia and finding microfilaria in nocturnal blood smears. The gross forms cause significant disability and misery. Early cases respond well to medical treatment. Intermittent pneumatic compression can provide relief for early swelling. Crucially, the value of surgical procedures for the limb swelling itself is largely unproven, and they are rarely performed.
Right. When it comes to treatment, the stage of the disease is absolutely crucial. Medical treatment is highly effective, but mainly in the early stages, before those gross, irreversible deformities of elephantiasis develop.
What's the main drug used?
Diethylcarbamazine is the primary medical treatment for killing the microfilariae and adult worms. For early limb swelling, before the skin becomes massively thickened, intermittent pneumatic compression therapy using inflatable sleeves to massage the limb applied intermittently for prolonged periods can provide significant symptomatic relief.
And surgery for the limb swelling itself. The source seems quite clear that it's not really a primary solution.
Yes, the text is explicit on this. It states that operations aimed at surgically reducing the size of the elephantiasis limb are rarely performed because their value is largely unproven, and they are rarely successful in providing lasting improvement. Surgical intervention is mainly reserved for managing associated treatable conditions.
Like the hydrocele.
Exactly, like the hydrocele that commonly underlies scrotal filariasis. The standard operation for a hydrocele excision or as version of the sac is performed. If there's significant scrotal elephantiasis as well, this might require excision of redundant, thickened scrotal skin at the same time.
So the surgical takeaway here seems to be understanding that progression from a simple mosquito bite to profound chronic lymphatic damage leading to elephantiasis. Recognizing that medical treatment is key early on, and crucially that surgical options for the devastating limb swelling itself are actually very limited, is vital for managing patient expectations and focusing interventions on the complications we can effectively treat, like hydroceles.
It's a really powerful example of a disease where the long-term physical consequences, while we can try to manage them symptomatically, are often beyond surgical cure with the techniques we currently have.
Okay, next up, let's tackle a parasitic disease that creates these rather strange cysts and can potentially appear in some surprising locations throughout the body. Hydatid disease.
Right, hydatid disease. This is caused by the larval stage of the dog tapeworm, specifically Echinococcus granulosus. While it's certainly common in many tropical regions, the source points out it's also prevalent in other parts of the world, particularly in rural areas closely associated with sheep farming. So you see it in places like the UK, Australia, South America, the Mediterranean.
And the life cycle involves dogs as the main definitive host.
Yes. The adult tapeworm lives in the small intestine of dogs and sheds these incredibly resistant eggs in their feces. Humans, along with intermediate hosts like sheep and cattle, become infected accidentally by ingesting these eggs, usually through oral contamination from direct contact with infected dogs or contaminated soil or food.
Okay, so inside the intermediate host, like a human or a sheep, the egg hatches, and the larva develops into this characteristic hydatid cyst. What's important about the structure of this cyst?
Well, the cyst typically has 3 layers. The outermost layer is the paracyst, which is actually a reaction from the host's own tissues walling it off. Inside that is the intermediate ectocyst, which is a non-cellular hyaline layer. It's not infectious itself. The really crucial inner layer is the endocyst, also called the germinal membrane. This membrane contains the viable parasites and is capable of producing daughter cysts, which bud off internally, and also protosolicises, the little larval heads that can develop into adult worms if ingested by a definitive host like a dog.
This source also mentions a variant.
Yes, Echinococcus multilocularis. This is found more in colder climates and behaves differently. Its cyst spreads more like a malignancy by actively invading surrounding tissues rather than just expanding like the E. granulosus cyst typically does. It's a much more difficult surgical problem.
The source provides a specific classification system for the more common E. granulosus cysts, which sounds important for management.
Absolutely. The WHO IWGE classification, which was standardized back in 2003, is based on the ultrasound appearance of the cyst and, crucially, its biological activity. It groups cysts into active, group 1, usually larger than 2 centimeters, fertile, containing viable parasites, often with daughter cysts. Transition, group 2, starting to degenerate, might still contain viable protoscolices, maybe showing membrane detachment, and inactive, group 3, degenerated, often partially or fully calcified, and unlikely to contain viable parasites.
And this classification is fundamental because...
Yeah, because it directly informs the appropriate management strategy, whether you should consider medical treatment, different types of surgical intervention, or perhaps just active surveillance or monitoring.
And the clinical presentation. The source calls it protein, which suggests it's highly variable.
That's exactly right. It's highly variable because the parasite can technically colonize virtually any organ in the body. However, the liver is by far the most common site, accounting for maybe 70% of cases, followed by the lungs, around 15 to 20%. But you can also find cysts in bone, kidney, spleen, brain, heart, muscles, pretty much anywhere.
And often they're asymptomatic for a long time.
Very often, yes. Cysts can grow slowly over many years without causing any symptoms and are frequently found incidentally when imaging, like an ultrasound or CT scan, is done for completely unrelated reasons.
When they do cause symptoms, it's often due to pressure effects.
Primarily, yes. Symptoms usually arise when the expanding cyst starts compressing adjacent structures. For example, a large hepatic cyst might cause a dull ache in the right upper quadrant by stretching the liver capsule. A large pulmonary cyst could cause shortness of breath or cough.
What about complications causing symptoms?
Cysts, especially those with daughter cysts, can sometimes rupture or communicate with adjacent structures. If daughter cysts rupture into the biliary tree, for instance, it can cause obstructive jaundice, cholangitis, or biliary colic, with symptoms related to the passage of parasitic material down the bile ducts.
Are there more dramatic or emergency presentations?
Yes. Raised intracranial pressure or unexplained headaches, particularly in someone from a known endemic or sheep-rearing area, should immediately raise suspicion for a cerebral hydatid cyst. A surgical emergency can occur if a cyst ruptures, often after relatively minor trauma. The patient might present with severe abdominal pain, and a CT scan would be diagnostic, showing the ruptured cyst.
And the most acute emergency?
Anaphylactic shock. This is rare but life-threatening. It happens if the cyst ruptures suddenly and releases a large amount of antigenic cyst fluid and protoscolices into the bloodstream or a body cavity. The source gives that dramatic example of a hepatic cyst located high up on the diaphragm, rupturing directly into the tracheobronchial tree. The patient might literally cough up whitish cystic fluid containing scolices.
That sounds terrifying. Okay, how do we diagnose this disease? High index of suspicion seems key.
It really is, especially with a relevant exposure history, like contact with dogs in a sheep farming area. Blood tests might show eosinophilia, but that's not specific. Serological tests, like ELISA or immunoelectrophoresis, can detect specific antibodies and are useful diagnostic aids, although false negatives can occur, especially with intact or calcified cysts.
Imaging is the cornerstone then.
Absolutely. Ultrasound and CT scans are the investigations of choice. CT typically shows a well-defined, smooth, space-occupying lesion, often with characteristic internal septations representing the walls of daughter cysts. Ultrasound is also very helpful, particularly for liver cysts, and can clearly show the cyst structure and features that align with the WHO classification. Ultrasound of the biliary tract might show abnormalities if the biliary system is involved. MRCP can be useful for visualizing multiple cysts and precisely delineating any communication with the biliary tree.
The source also mentions specific imaging signs related to complications.
Yes, signs that suggest impending or actual rupture. The meniscus or crescent sign on a chest x-ray indicates air has entered between the paracyst and the endocyst membrane, suggesting detachment and possible impending rupture into the airways. The water lily sign, typically seen on CT, occurs in a ruptured cyst where the inner endocyst membrane has collapsed and floats within the remaining fluid, resembling a water lily.
Okay, quick diagnosis summary from the source box. In the UK, suspected especially in sheep farmers. Liver is the most common site, then lung. Elective presentation is often a painful liver lump. Emergency presentation is typically anaphylactic shock from rupture. CT is usually the best imaging modality, showing a smooth space-occupying lesion, often with septa. The WHO classification based on ultrasound appearance, unilocular, hydatid sand, septation daughter cysts, detached membrane, solid matrix calcification, is crucial for guiding management.
Right, and treatment is complex. Ideally, it should be managed in a specialized tertiary unit with a multidisciplinary team approach involving hepatobiliary surgeons, infectious disease physicians, interventional radiologists, and others.
Is medical treatment ever sufficient on its own?
Medical treatment using benzimidazole drugs, mainly albendazole, sometimes combined with praziquantel, is an important component. It's often used before or alongside interventional procedures to reduce the viability of the parasite and decrease the risk of recurrence if there's spillage. Sometimes, for certain types of small active cysts, like WHO type CE1, prolonged medical therapy alone might be considered, but often intervention is needed.
So surgery or intervention is often required. What are the options for hepatic cysts, being the most common site?
The strategy really depends heavily on that WHO classification, cyst activity, as well as the number, size, and anatomical position of the cysts. Procedures range from minimally invasive techniques like PAIR, that's puncture, aspiration, injection of a scolicidal agent, and reaspiration. PAIR is typically done for suitable uncomplicated cysts like CE1 and some CE3A, often after a pre-treatment course of albendazole.
And more definitive surgical options.
These include more radical approaches like total or partial paracystectomy, where the entire cyst, including the surrounding host reaction layer, paracyst, is removed. This aims for complete eradication but carries higher risks. Hepatic segmentectomy, removing the part of the liver containing the cyst, might be suitable for peripheral lesions.
Scolicidal agents sound crucial during surgery.
Absolutely critical. During any procedure where the cyst might be opened or ruptured, scolicidal agents must be used to kill any viable protoscolices within the cyst fluid and prevent them from spilling and causing secondary hydatidosis, new cysts forming. Common agents mentioned are hypertonic saline, like 15-20%, ethanol, 75-95%, or 5% povidone iodine. However, the source specifically warns about the risk of sclerosing cholangitis, inflammation and scarring of bile ducts, if povidone iodine accidentally leaks into the biliary tree through an unrecognized communication.
Laparoscopic approaches are being used too.
Yes, increasingly so for selected cysts. Laparoscopic techniques can be used to perform procedures like marsupialization or deroofing, opening the cyst, evacuating contents, managing the cavity, often by sewing omentum into it, or even laparoscopic cystoparacystectomy for smaller, more superficial cysts.
And what about inactive cysts?
Asymptomatic, clearly inactive cysts, WHO group CE3b, CE4, CE5, calcified degenerated, are typically just monitored with follow-up ultrasound scans, often referred to as a watch-and-wait approach.
What about pulmonary hydatid cysts, the second most common site? How is treatment different there?
For pulmonary cysts, surgery is generally considered the mainstay of treatment. Medical therapy is less successful here, particularly for large, complicated, recurrent, or ruptured cysts. The primary principle of surgical management in the lung is to preserve as much functional lung tissue as possible.
What procedures are used?
Options range from simple cystotomy, incising the cyst, with evacuation of contents and capitanage, suturing the walls of the residual cavity together to obliterate the space, to paracystectomy, removing the cyst within its intact capsule if possible, segmentectomy, removing the lung segment containing the cyst, or very rarely, pneumonectomy, removing the entire lung, if the disease is extremely extensive.
Okay, let's summarize treatments. Hepatic treatment summary from SourceBox. Managed in a tertiary multidisciplinary unit. Asymptomatic actinous cysts are usually monitored. Active cysts typically get a full course of albendazole first. Procedures include peri-IR, paracystectomy momenoplasty. Hepatic segmentectomy management is customized based on cyst type and location. Laparoscopic approaches are increasing. Pulmonary summary. Second most common organ. Size varies. Presentation can be incidental or emergency rupture. CXR might show meniscus crescent sign. CT, the water lily sign. Ideal treatment is surgical, with various lung-sparing options preferred.
Right. And for surgical mastery here, I think understanding the sheer potential for these cysts to appear almost anywhere, the absolutely critical role of that WHO classification in guiding every management decision, and the specific surgical techniques required not just to remove the cyst, but crucially to prevent spillage, manage potential biliary communications, and avoid anaphylaxis using salicylated agents. Those are the key elements. The risks involved, especially with rupture, make this a particularly challenging and sometimes dramatic surgical condition.
Definitely. Okay, switching now to a chronic infectious disease with a really deep historical context, but sadly, ongoing global impact and significant surgical sequelae. Leprosy, also known as Hansen's disease.
Yes, leprosy. It's a chronic infectious disease caused by the bacterium Mycobacterium leprae, which is an acid-fast bacillus related to the one that causes TB. While it's been recognized for millennia and often thought of historically, it remains prevalent in many tropical regions today. And a striking aspect the source highlights is the significant social stigma and discrimination that sufferers continue to face, often compounded by the historical use of terms like leper.
How is it actually transmitted? It's not highly contagious, is it?
No, it requires prolonged close contact with an infected individual. It's typically thought to be transmitted via nasal secretions from untreated patients with the multibacillary lepromatous form. Infection is usually contracted in childhood or early adolescence, but it has a notoriously long incubation period, often several years, before any clinical manifestations appear.
And where does the bacillus primarily like to live in the body? The source mentions temperature preference.
Exactly. Mycobacterium leprae prefers slightly cooler body temperatures. This strongly influences its distribution in the body. It tends to affect the nasal mucosa, the skin, especially exposed areas like the ears and face, and critically peripheral nerves, particularly where they run superficially close to the skin or pass through tight bony canals. Examples given include the facial nerve at the stylomastoid foramen, the ulnar nerve at the elbow, or the median nerve at the wrist.
And the disease is classified based on the host's immune response, right? Lepromatous versus tuberculoid.
Yes, broadly speaking, it's a spectrum, but the two poles are key to understand. Lepromatous leprosy, LL, occurs in individuals with a poor cell-mediated immune response to the bacteria. They tend to have widespread bacilli throughout their tissues, a high bacterial load, and develop extensive skin lesions like nodules and plaques. However, the direct tissue damage from the immune system itself might be less severe initially.
And tuberculoid leprosy.
Tuberculoid leprosy, TT, occurs in individuals with a strong cell-mediated immune response. They have very few bacilli because their immune system is actively fighting them. They form well-organized granulomas, especially around nerves, with lots of lymphocytes and giant cells. But here's the paradox. The tissue damage, especially to nerves, is often more severe and localized because it's caused primarily by the intense immune response itself rather than the bacteria directly. So tissue damage is inversely proportional to the bacterial load. There are also intermediate forms called borderline or dimorphous leprosy that sit between these two poles.
So in the tuberculoid form, the body's attempt to fight the infection can actually cause more nerve damage. That seems crucial.
Precisely. And it is this nerve damage occurring across the spectrum, but particularly prominent in tuberculoid and borderline forms, that leads to many of the chronic, devastating surgical problems associated with leprosy.
Okay, let's talk clinical features then. What does a surgeon need to be able to recognize?
Well, it's a slowly progressive disease affecting the skin, the upper respiratory tract, especially the nose, and critically, those peripheral nerves. Tuberculoid leprosy often presents with early, localized nerve damage. You might find thickened, tender peripheral nerves that can actually be palpated. The ulnar nerve at the elbow is a classic example. Skin lesions are typically few, asymmetrical, well-defined patches, leprids that might be hypopigmented or reddish, often with elevated edges. They tend to be dry, rough, and characteristically they are anesthetic, they lack sensation.
And lepromatous leprosy looks different.
Yes, it's generally more symmetrical and expensive. Skin lesions start as pale macules that gradually coalesce into diffuse plaques and nodules called lepromas. Acute exacerbations can lead to a rapid development of these nodules, especially on the face, resulting in that striking appearance known as leonine facies, a lion-like appearance. Later on, the chronic skin infiltration can lead to wrinkling and an aged look, loss of eyebrows, particularly the outer parts, and destruction of the nasal cartilages and septum. This causes the characteristic collapse of the nasal bridge and tilting up of the nose tip.
And the nerve damage causes specific facial and limb deformities that surgeons often deal with.
Absolutely critical for surgeons to recognize these patterns. Facial nerve paralysis, especially affecting branches as they exit bony canals or cross the zygoma, is common. This can lead to incomplete eye closure or lagophthalmos due to paralysis of the orbicularis oculi muscle.
Which leads to eye problems.
Yes, chronic exposure leads to watering eyes, epiphora, recurrent conjunctivitis, exposure keratitis, damage to the cornea, and ultimately, if not managed, potentially irreversible blindness.
And the hands and feet. These are classic sites for leprosy-related deformities.
Absolutely. Chronic damage to the ulnar and median nerves in the arm leads to paralysis and wasting of the small intrinsic muscles of the hand, resulting in the characteristic claw hand deformities. But equally devastating is the loss of sensation anesthesia in the hands. This makes patients highly prone to repeated, unnoticed burns and injuries, leading to secondary infections and tissue loss.
Similar problems in the feet.
Yes. Damage to the posterior tibial nerve can lead to claw toes. Damage to the lateral popliteal, common peroneal nerve, which is often palpably thickened behind the head of the fibula, causes foot drop, the inability to lift the front of the foot when walking. And again, the anesthesia of the feet is a major problem, making them incredibly vulnerable to repetitive trauma from walking, leading to trophic ulceration, ulcers due to nerve damage and pressure, chronic, deep infections involving bone, joint contractures, and even spontaneous auto-amputation of digits over time.
The source also mentions testes involvement.
Yes, testicular involvement can lead to atrophy and subsequently gynecomastia, breast enlargement in males, due to hormonal changes.
So many of the visible deformities are actually secondary to the primary nerve damage and the resulting loss of sensation and motor function. How is the diagnosis definitively confirmed?
While the clinical features, especially the combination of skin lesions and thickened nerves with sensory loss, are often highly suggestive, confirmation relies on microbiological examination and histology. A slit skin smear, taking a small sample of tissue fluid from an active skin lesion or earlobe, can be examined for acid-fast bacilli, AFB, particularly in the lepromatous end of the spectrum where bacilli are numerous. A skin biopsy from the edge of an active lesion sent for histology will show characteristic changes, such as the specific patterns of inflammation in granulomas, epithelioid granulomas surrounding nerves, and tuberculoid leprosy.
Okay, pathology summary from Sourcebox. Chronic but curable infection by M. leprae. Found in tropical, resource-poor countries, mostly the Indian subcontinent. Transmission likely via nasal secretions. Organism prefers cooler body parts. Poor hygiene is a factor. Incubation period is years, often contracted in childhood. Lepromatous type, a poor immune reaction, high bacterial load. Tuberculoid type, use stronger resistance, low bacterial load, but more localized immune-mediated damage, especially nerves. Diagnosis summary. Typical clinical features plus awareness are key. Look for the aged face, collapsed nasal bridge, eye changes, thickened peripheral nerves, anesthetic skin patches, claw hand stows, foot drop, trophic ulcers are characteristic. Confirmation via microbiology, AFB on smears, and typical histology on skin biopsy.
Right, and the good news is that modern treatment has truly revolutionized the management of leprosy. Historically, treatments were pretty ineffective, based on things like extracts from Hypnocarpus tree seeds.
But now it's effectively curable with multi-drug therapy, or MDT.
Yes, absolutely. According to WHO guidelines, a full course of MDT for usually 12 months, sometimes longer for multibacillary cases, is the mainstay, and is highly effective at killing the bacteria and rendering the patient non-infectious relatively quickly. The standard MDT regimen typically involves a combination of dapsone, rifampicin, and clofazimine.
What about inflammatory reactions during treatment?
Yes, patients can experience acute inflammatory episodes called leprosy reactions during or even after MDT. These are immune-mediated and can cause sudden nerve damage, so they need to be recognized and managed promptly, usually with corticosteroids like prednisolone.
So the infection itself is cleared medically, but surgery plays a crucial role in managing the lasting damage, the sequelae.
Exactly. Surgical treatment comes into play primarily in the advanced stages, long after the active infection is controlled. Its purpose is to address the functional disabilities, the cosmetic disfigurement, and the visual problems that result from the chronic, often irreversible, nerve damage and its consequences. This area is really the domain of specialized surgeons working together as a team, often involving plastic surgeons, ophthalmologists, and hand or orthopedic surgeons.
What kind of reconstructive procedures are typically done?
For the hands, reconstructive surgery aims to restore functional grasp and pinch mechanisms that are lost due to intrinsic muscle paralysis. This often involves specialized tendon transfer procedures, like the Brand or Tovey transfers mentioned in the source, where tendons from working muscles are surgically rerouted to substitute for the function of the paralyzed lumbricals and interossae.
And for the feet?
For foot drop caused by common peroneal nerve damage, interventions include providing supportive bracing, like a foot drop splint, AFO, or performing surgical tendon transfer. A common transfer is moving the tibialis posterior tendon through the interosseous membrane to the dorsum of the foot to provide active dorsiflexion. For the chronic ulcers resulting from the insensate foot, management involves meticulous debridement of dead tissue, controlling infection, and critically protective measures like total contact casting or specialized footwear to offload pressure and allow healing, alongside patient education on foot care.
And sometimes amputation is needed.
In very advanced cases, yes, where there's severe deformity, intractable chronic infection involving bone, or non-healing ulcers threatening systemic sepsis, a general surgeon might be involved for amputation as a salvage procedure. Drainage of secondary abscesses is also sometimes necessary.
And it's important that these surgical procedures are done while the patient is still receiving or has completed their anti-leprosy drugs.
Yes, concurrent or completed anti-leprosy drug treatment is essential. Surgery doesn't treat the infection itself. The source strongly emphasizes the critical need for a multidisciplinary team approach throughout the patient's journey, involving specialists from infectious diseases, plastic surgery, ophthalmology, orthopedics, hand surgery, physiotherapy, occupational therapy, and social work.
The source also really stresses the role of education and prevention.
Absolutely. Two key aspects. Patient education, encouraging people in endemic areas to recognize early signs, like skin patches with sensory loss, and seek diagnosis and treatment before severe, irreversible nerve damage occurs. And secondly, public education to combat the pervasive stigma and discrimination associated with leprosy, which often prevents people from seeking help early. These are highlighted as cornerstones in preventing advanced disease and disability.
Okay, treatment summary from the source box. Multi-drug therapy MDT for about a year is standard. A team approach involving various surgical subspecialties is needed for reconstruction of deformities. Patient and public education are keystones in prevention.
Right. And for mastery, I think recognizing that leprosy, while a chronic curable infection, has its major surgical relevance in the lasting specific deformities caused by irreversible nerve damage. That's crucial. Understanding that complex reconstructive procedures are often needed long after the bacteria themselves are gone, and appreciating the intricate interplay between the medical management of the infection and the surgical management of its consequences really highlights the need for integrated, long-term, multidisciplinary care.
Absolutely. Okay, let's move on now to a condition characterized by a very distinctive clinical triad, mycetoma.
Ah, yes, mycetoma. This is a chronic, specific granulomatous inflammatory disease. It's progressive and often destructive, affecting the skin initially, then subcutaneous tissues, and frequently invading deeper structures like muscle and bone over time. What's unique about it is that it can be caused by two different groups of organisms, either true fungi, in which case it's called eumycetoma, or certain types of filamentous bacteria, specifically actinomycetes, leading to actinomycetoma.
And the hallmark triad that signals this condition.
The source describes it as pathognomonic, meaning it's virtually diagnostic when present. First, a painless subcutaneous mass or swelling. Second, the presence of multiple draining sinus tracts emerging from that mass. And third, a discharge coming from those sinuses that contains visible grains.
Grains, like sand.
Sort of. They're actually macroscopic colonies of the causative organism, clumped together and embedded in a matrix produced by the host or the organism. When you see that triad, you should strongly suspect mycetoma. It's a condition that causes significant tissue destruction, deformity, disability, and sadly can sometimes even be fatal, particularly if it spreads systemically or affects vital structures like the cranium.
The geography for this condition is quite specific too, isn't it? The mycetoma belt?
Yes, it predominantly occurs in a specific tropical and subtropical zone, often referred to as the mycetoma belt, which lies roughly between 15 degrees south and 30 degrees north latitude. Countries within this belt known for a high incidence include Sudan, India, Mexico, Senegal, and others.
How do people actually get infected? Is it contagious?
No, crucially, it's not contagious from person to person. The causative organisms, whether fungal or bacterial, live as saprophytes in the soil and on vegetation, particularly things like thorny acacia trees in some regions. Infection typically occurs via traumatic inoculation. The organism gets introduced directly into the subcutaneous tissue through a breach in the skin. This is often a minor, sometimes unnoticed trauma, like a thorn prick, especially in individuals who walk barefoot or work manually in agricultural settings.
Which explains why the foot is the most common site.
Exactly. The source states the foot is affected in around 70% of cases, followed by the hand, around 12%, simply because these are the areas most exposed to minor trauma from the environment in endemic regions.
Okay, histology summary from the source box. Occurs in the mycetoma belt, caused by either fungi, eumyceto, or bacteria, actinomycetoma. Infection follows trauma inoculation from soil vegetation, often affecting the foot. It's a chronic, progressive, destructive inflammation leading to tissue destruction, deformity, disability, and potentially death.
The disease typically begins quite insidiously as a slowly progressive, painless, subcutaneous swelling or nodule at the site where the organism was inoculated. This initial swelling gradually increases in size. Its feel can vary, sometimes firm and rounded, sometimes softer or more lobulated. The overlying skin becomes stretched, smooth, shiny, and often attached to the underlying mass. Altered pigmentation, either hypo or hyperpigmentation, can also occur over the lesion.
And those hallmark sinuses and discharge develop later as it progresses.
Yes. As the granulomatous inflammatory process continues, multiple secondary nodules tend to develop within the main mass. These nodules eventually suppurate, form pus, and then rupture through the skin surface, forming multiple sinus tracts that drain to the outside. A characteristic feature is that these sinuses might close over temporarily, only for new ones to open up nearby, while older ones might heal with scarring. The discharge itself can vary sidereous, serosanguineous, or frankly purulent.
And the grains are visible in the discharge.
Yes, a key feature, especially during active phases, is the discharge of these visible grains. They are essentially the microcolonies of the causative organism. Their color, which can be black, yellow, white, or red, depending on the specific fungus or bacterium involved, can provide a clue to the underlying pathogen. Pain is typically not a major feature early on, usually only supervening if there's a significant secondary bacterial infection of the sinuses and tissues.
While the foot and hand are the most common sites, the source lists quite a few other potential locations.
Yes, reflecting where minor trauma can occur, it can affect the knee, arm, leg, head, and neck, including the scalp and face, the thigh, and the perineum. Much rarer sites mentioned include the chest wall, abdominal wall, facial bones, mandible, testes, paranasal sinuses, or even the eye.
The source makes a really important point about the spread of the disease and how the clinical appearance can be deceptive.
Extremely important, particularly for surgical planning. Mycetoma primarily spreads locally, with the colonies tending to follow fascial planes between muscles and other tissues. Lymphatic spread is less common than local extension, but does occur more frequently in actinomycetoma than eumycetoma, usually involving the regional lymph nodes. Repeated, inadequate surgical attempts can actually increase the risk of lymphatic spread.
So the surface appearance doesn't tell the whole story.
Definitely not. The appearance on the surface might suggest a relatively localized lesion, but there can be deep, extensive connecting tracts and satellite foci of infection extending far beyond what's apparent externally, often involving muscle and bone. This is why the source strongly warns against attempting surgery under local anesthesia. It risks inadequate excision and local spread of the infection. Constitutional disturbances like cachexia, wasting, and anemia are usually late signs, typically indicating severe secondary infection or sepsis. Cranial mycetoma, if the infection spreads to the skull, is particularly dangerous and can be fatal.
Given that it presents as a mass, sometimes with bone involvement, it must have a fairly wide differential diagnosis.
It does. In endemic areas, it needs to be differentiated from other conditions that can cause chronic subcutaneous swellings, sinuses, or bone lesions. Examples mentioned include Kaposi sarcoma, malignant melanoma, fibroma, maybe a chronic foreign body granuloma. If there's bone destruction seen on X-ray but no sinuses, tuberculosis might be considered. Radiographically, advanced mycetoma involving bone can sometimes mimic primary bone tumors like osteogenic sarcoma, occasionally even showing a sunray peristeel reaction or a Codman's triangle. Primary mycetoma originating in bone needs to be distinguished from chronic osteomyelitis, osteoclastoma, bone cysts, or even syphilitic osteitis.
So the clinical dictum mentioned seems crucial.
Yes, the source states a crucial clinical rule of thumb for endemic areas. Any subcutaneous swelling must be considered a mycetoma until proven otherwise. It really emphasizes the need for a high index of suspicion.
Okay, so how do we confirm the diagnosis and, importantly, assess the true extent of the disease?
Imaging is absolutely essential, both for diagnosis and staging. Plain radiography is often the first step. Early on, it might just show soft tissue swelling, maybe some calcification. As it progresses, it can show bone involvement, typically cortical erosion or scalloping from the outside, peristeel reaction, like those sunray spicules, and eventually characteristic multiple, small, punched-out lateral cavities within the bone.
What about ultrasound and MRI?
Ultrasound can be very helpful. It can sometimes help differentiate eumycetoma from actinomycetoma based on the appearance of the grains and cavity walls. Eumycetoma often shows sharp, bright hyperechoic echoes representing the fungal grains within thick-walled cavities. Actinomycete grains are often less distinct. Ultrasound is also useful for getting a better sense of the size and superficial extent of the lesion, which aids surgical planning. MRI, however, is probably the best imaging modality for assessing the true extent, especially deep soft tissue involvement and bone destruction.
Does MRI have characteristic signs?
Yes, the source describes characteristic MRI findings. Multiple small, high signal intensity lesions representing the granulomas, interspersed within a low intensity fibrous matrix, and perhaps most specifically the dot and circle sign, where the low signal intensity grain is seen as a dot within the high signal intensity circle of the granuloma. Seeing this sign is highly suggestive of mycetoma. CT is less specific than MRI, but can also help detect early bone involvement.
What about getting a tissue diagnosis? How is that best done?
Histopathological diagnosis from a biopsy is definitive. However, it needs to be a deep biopsy, preferably including some of the grains, and importantly, it should be performed under general or regional anesthesia because of that risk of local spread with local infiltration. Part of the biopsy specimen should be sent fresh and fixed for culture, and part fixed in formalin for histology. The lab needs to be alerted to the suspicion of mycetoma. Histology shows the characteristic grains surrounded by different types of host inflammatory reactions.
FNAC is also mentioned.
Yes, fine needle aspiration cytology is mentioned as an accurate, simple, rapid, and sensitive method that can often distinguish between the fungal mycetoma and bacterial actinomycetoma types, which is crucial for guiding initial treatment. Culture of grains obtained from a deep surgical biopsy, not from the sinus discharge, which is often contaminated, is needed to identify the specific causative organism and determine its drug sensitivities. Serological tests like immunoelectrophoresis or ELISA can detect specific antibodies and can be valuable for diagnosis, especially if the classic triad isn't present, and also helpful for monitoring treatment response.
Okay, diagnosis summary from the source box. Usually late presentation because it's painless. Look for the triad. Painless mass, multiple sinuses, discharge with grains. Clinical picture can be very deceptive regarding deep extension, may spread to lymph nodes, can be confused with Kaposi's sarcoma or radiologically mistaken for osteosarcoma. MRI showing the dot and circle sign is characteristic. Open biopsy or FNAC are confirmatory.
Right. And the management of mycetoma absolutely requires a combined physician and surgeon approach. Critically, the medical treatment differs significantly depending on whether it's eumycetoma, fungal, or actinomycetoma, bacterial. You have to know which type you're dealing with.
So antibiotics for the bacterial form, antifungals for the fungal form.
Exactly. Actinomycetoma is treated with long-term cycles of combined antibiotic therapy. The source mentions regimens including drugs like amikacin sulfate plus cotrimoxazole, or second-line agents like amoxicillin clavulanic acid, rifampicin, sulfonamides, gentamicin, or kanamycin. These treatments often need to be continued for many months, even years, and carry risks of serious side effects that need monitoring.
And eumycetoma.
Eumycetoma is treated with long-term systemic antifungal agents, such as ketoconazole, itraconazole, or voriconazole. Again, treatment durations are often very long, up to a year or more, and require careful monitoring for potential side effects, especially liver toxicity with some agents.
Are these medical treatments always curative on their own?
For actinomycetoma, prolonged combination antibiotic therapy can often be curative, although surgery might still be needed for residual disease or complications. For eumycetoma, however, the current antifungal drugs are often not curative on their own, especially for extensive disease. Their main role is often to help reduce the inflammatory burden, localize the infection, and encapsulate the fungal grains, making the lesion more amenable to subsequent surgical excision. Medical treatment, whichever type, needs to be continuous until cure is achieved and should typically continue post-operatively to prevent recurrence.
So when does surgery come into the picture?
Surgery is indicated for several reasons. For small, well-localized lesions where complete excision seems feasible, for lesions that are resistant to medical treatment, or sometimes for massive disease after an initial course of medical therapy has reduced the size and inflammation, making surgery safer and more effective debulking.
And the surgery needs to be extensive.
Yes, given the deceptive nature of its spread, surgical excision needs to be wide, going well beyond the apparent clinical margins and often extending into deeper tissue planes to ensure all infected tissue and grains are removed. Surgical options range from wide local excisions for smaller lesions to major debulking procedures for very large masses, or, unfortunately, sometimes amputation.
Amputation sounds drastic, but sometimes necessary.
Yes, the source indicates amputation is required in a significant minority of cases, maybe 10–25%. It's usually reserved as a life-saving measure for very advanced refractory disease, especially cases complicated by severe secondary bacterial infection, extensive bone destruction, or where function is already completely lost.
Recurrence rates sound worryingly high after treatment.
They are. The source reports recurrence rates ranging from 25% up to 50%. This high rate is often attributed to several factors: inadequate initial surgical excision, not getting wide enough margins, the historical or inappropriate use of local anesthesia risking spread, lack of surgical experience with these complex cases, poor patient compliance with the necessary long-term and often expensive medical treatment regimens, and insufficient health education about the disease and the importance of follow-up.
Management summary from the source box. Requires combined physician-surgeon management. Medical treatment involves appropriate long-term antibiotics for actinomycetoma or antifungals for eumycetoma, being aware of serious drug side effects. For large lesions, medical treatment is often used first to reduce size, followed by excision. Surgery requires wide excision or sometimes amputation as a life-saving measure. Recurrence rates are high.
So, for surgical mastery of mycetoma, recognizing that distinctive triad is key. Understanding the geographical context, the mycetoma belt, being able to differentiate clinically or via investigations between the fungal and bacterial types, because that dictates the medical treatment, appreciating that deceptive clinical picture which demands wide surgical excision and often advanced imaging like MRI with that characteristic dot and circle sign, and finally, understanding the reasons for the high recurrence rate, emphasizing the need for meticulous surgical technique combined with prolonged, compliant medical follow-up. It's a really challenging condition.
Definitely sounds like it. Okay, moving now to a viral illness, one largely controlled by vaccination in many parts of the world, but sadly still causing profound surgical problems where it persists. Poliomyelitis.
Yes, polio. Caused by an enterovirus, it tragically still affects children in some parts of the world where vaccination coverage isn't complete, despite the availability of highly effective vaccines for decades. The virus typically enters the body via inhalation or ingestion. The spectrum of resulting symptoms is incredibly wide, ranging from just a mild fever and headache in most cases to extensive, devastating paralysis in a minority. The most severe form, bulbar polio, affects the respiratory and pharyngeal muscles and is often incompatible with life without respiratory support.
The surgical relevance, though, comes from its specific target within the nervous system.
Exactly. The poliovirus has a specific predilection for attacking the anterior horn cells in the spinal cord. These are the motor neurons that directly control muscle movement. Damage or destruction of these cells results in a lower motor neuron type of paralysis, flaccid weakness, or paralysis of the muscles supplied by those neurons. The source notes that muscles in the lower limbs are affected about twice as frequently as those in the upper limbs.
And while paralysis is rare overall, the consequences are severe.
Yes, tragically. Even though only a small percentage of infected individuals, maybe 1–2%, develop paralytic symptoms, the resulting permanent disability causes immense personal misery and requires significant lifelong rehabilitation efforts.
When a child presents acutely with fever and muscle weakness, other conditions need to be considered, right?
Absolutely. The source specifically mentions the need to rule out Guillain-Barré syndrome, GBS, which is another cause of acute flaccid paralysis. A key differentiating feature noted is that GBS typically involves sensory symptoms and signs as well, like numbness, tingling, or pain, whereas the paralysis in polio is usually purely motor, without significant sensory loss. Analysis of the cerebrospinal fluid, CSF, obtained via lumbar puncture can also help distinguish between these conditions.
Initial management during the acute illness is primarily medical and supportive, I assume.
Yes. During the acute phase, management focuses on supportive care, managing fever and pain, and crucially, providing respiratory support if the breathing muscles are affected. The orthopedic surgeon's role comes later.
When does the surgeon get involved then?
Surgical management is primarily focused on addressing the residual paralysis and the resulting functional deficits and deformities that persist after the initial acute phase of the illness has resolved. Rehabilitation is the main goal. The operations performed are highly tailored to the individual patient's specific pattern of muscle weakness and the resulting disability way, things like joint contractures or instability.
The source mentioned that improvement can happen over time.
Yes. It notes that muscle function can continue to improve spontaneously for up to 2 years after the onset of paralysis, particularly in children. It also points out that many patients learn to adapt incredibly well and compensate for their muscle weakness by developing clever trick movements to achieve function.
Which sounds like surgeons need to be very cautious before intervening surgically.
Yeah.
Don't want to disrupt those adaptations.
They absolutely do. The source really stresses this point. Surgical treatment in the chronic phase of polio is the domain of highly specialized orthopedic surgeons who have specific expertise in managing neuromuscular conditions. They need to work in very close collaboration with physiotherapists for detailed assessment and long-term rehabilitation planning. Surgery is only considered after a very careful, individualized assessment of the patient's function, needs, and potential for improvement. The decision is typically made by a multidisciplinary team involving the orthopedic surgeon, perhaps a neurologist, the physiotherapist, and orthotist who specializes in braces and splints, and critically, the patient and their family.
The source briefly mentions the types of surgical procedures used for the paralysis itself.
Yes, for the residual paralysis, common surgical interventions fall into two main categories. Tendon transfers, where the tendon of a working muscle is surgically detached and rerouted to a new insertion point to substitute for the function of a paralyzed muscle, for example, transferring a wrist flexor to act as a finger extensor. And arthrodesis, which is surgical fusion of a joint, performed to provide stability to a joint that has become unstable or flail due to surrounding muscle weakness, for example, fusing the ankle or wrist. The source explicitly states that the technical details of these complex procedures are beyond its scope, directing the reader to specialist orthopedic texts, which really highlights their complexity and the need for specialized training.
It's definitely worth acknowledging the huge impact of global health efforts regarding polio.
Indeed. The source specifically notes the success of global vaccination programs, highlighting India being declared polio-free in 2012 as a major public health achievement, although sadly the virus unfortunately persists in a small number of countries, posing an ongoing threat until it's fully eradicated globally.
Okay, summary from the source box. Poliomyelitis is a viral illness, preventable by vaccination. Presents with fever, headache, and muscular paralysis, characteristically without sensory loss, frequently affecting the lower limbs more than the upper. Early treatment is mainly medical and supportive. Surgery is only considered after very careful assessment in the chronic phase, recognizing that many patients learn to live effectively with their disability. Surgery for residual paralysis includes specialized procedures like tendon transfers and arthrodesis, and is firmly the domain of specialist orthopedic surgeons working within a rehabilitation team.
So for surgical mastery, while thankfully primary polio infection might be rare for many surgeons to encounter now due to vaccination, understanding how a viral infection can cause such specific, permanent patterns of nervous system damage leading to complex musculoskeletal deformities is crucial background knowledge. Recognizing that surgical intervention is a highly specialized, multidisciplinary effort aimed purely at rehabilitation and improving function after the acute phase, rather than being a cure for the initial infection itself, is a really key distinction.
Makes perfect sense. Okay, moving on now to a form of chronic pancreatitis that has a very different origin story compared to the type most commonly seen in Western countries, tropical chronic pancreatitis.
Yes, this is described as a distinct entity. It primarily affects a younger population, typically people under the age of 40, often from poor socioeconomic backgrounds in resource-limited countries. The source specifically mentions a high incidence in southern India. And the absolutely crucial point differentiating it up front is that its etiology is definitively not related to alcohol consumption, which is the most common cause of chronic pancreatitis in many other parts of the world.
So if not alcohol, what are the suspected causes? The etiology sounds a bit obscure.
It is somewhat obscure, but the leading theory, as mentioned clearly in the source, relates to chronic malnutrition combined with dietary factors, specifically the regular consumption of large amounts of cassava, also known as tapioca, which is a cheap staple food for many impoverished populations in the tropics.
Cassava, how's that linked to pancreatitis?
Well, cassava naturally contains cyanide derivatives, specifically cyanogenic glycosides. Normally, the liver detoxifies these compounds using sulfur-containing amino acids obtained from dietary protein. The theory posits that an individual is consuming a diet chronically deficient in these essential amino acids, which is common in severe malnutrition. This detoxification pathway becomes overwhelmed. This leads to cyanogen toxicity, which is thought to directly damage the pancreas over time. The fact that familial clustering of cases is sometimes seen, where multiple family members sharing the same deficient diet develop the condition, adds some weight to this cassava malnutrition theory. Genetic factors might also play a role, but the dietary link is strongly suspected.
Interesting. What does the pancreas actually look like pathologically in this condition?
Macroscopically, the pancreas is typically described as being firm and nodular. This is due to extensive fibrosis, particularly periductal fibrosis scarring developing around the pancreatic ducts. But the most striking and characteristic feature is the presence of large, hard intraductal stones composed mainly of calcium carbonate.
Stones inside the pancreatic ducts.
Yes, multiple stones, often quite large, sitting within the dilated pancreatic ducts. They can vary in size and shape, and sometimes they become branched, resembling the staghorn calculi occasionally seen in the kidney's collecting system. The pancreatic ducts themselves are typically dilated upstream from where these stones are causing obstruction. Microscopically, the predominant features are fibrosis affecting tissue within the lobules, between the lobules, and around the ducts, along with infiltration by chronic inflammatory cells like plasma cells and lymphocytes.
And unfortunately, there's a significant long-term risk associated with this condition.
Yes, the source explicitly states that there's a high incidence of pancreatic cancer developing in patients with tropical chronic pancreatitis. This is likely related to the chronic inflammation, ductal obstruction, and possibly genetic factors associated with the condition itself.
Okay, pathology summary from the source box. Seen in resource-poor countries, linked to malnutrition, specifically not alcohol. Cassava ingestion, leading to cyanide compound toxicity, is strongly suspected. Pathologically characterized by dilated pancreatic ducts containing large intraductal calcium carbonate stones and extensive fibrosis. Critically, there is a high associated incidence of pancreatic cancer.
Clinically, the typical patient presenting is usually male under the age of 40 and from a poor socioeconomic background. The cardinal symptom is usually severe chronic abdominal pain, which can be quite debilitating. In addition, patients often present with signs and symptoms of significant pancreatic insufficiency, both endocrine and exocrine.
Meaning diabetes and digestion problems.
Exactly. They frequently develop diabetes mellitus, often presenting with severe thirst, polydipsia, and polyuria. And they develop exocrine insufficiency leading to steatorrhea, passing bulky, fatty, foul-smelling stools due to the lack of digestive enzymes, which contributes to profound malnutrition and emaciation. So the patient often looks quite ill and wasted.
They often present with a specific type of diabetes associated with this.
Yes. The source mentions it's often referred to specifically as fibrocalculous pancreatic diabetes, FCPD, highlighting its direct link to the pancreatic stones and fibrosis. It behaves like type 1 diabetes, requiring insulin. Routine blood tests confirm the diabetes. Serum amylase levels are usually normal between attacks, but can become elevated during acute exacerbations of pancreatitis, which can still occur on top of the chronic condition.
What's the key initial investigation that often clinches the diagnosis?
A plain abdominal radiograph. The simple X-ray is often diagnostic because it typically shows the characteristic pancreatic calcification. You can actually see the discrete radio-opaque stones lying within the outline of the pancreatic ductal system. Ultrasound and CT scans are then used to further confirm the diagnosis, better delineate the extent of the disease, visualize the dilated ducts and the stones within them, and importantly rule out any associated complications like pseudocysts or malignancy.
ERCP is mentioned, but with a specific limitation on its use.
Yes, the source is quite clear that ERCP, endoscopic retrograde cholangiopancreatography, should only be used as an investigative tool in this condition if it is being combined with a therapeutic procedure at the same time. This is because ERCP is invasive and carries risks, like inducing pancreatitis. So it's generally reserved for situations where an intervention, such as attempting endoscopic removal of stones located in the main pancreatic duct near the head of the pancreas via sphincterotomy, is planned during the same session. It's not usually done purely for diagnosis anymore, given the quality of cross-sectional imaging like CT and MRCP.
Okay, diagnosis summary from the source box. Patient is typically a type 1 diabetic under the age of 40. Serum amylase may be elevated during acute flares, but often normal otherwise. Plain abdominal X-ray showing pancreatic stones, calcification is characteristic. Ultrasound and CT confirm the diagnosis and duct dilatation stones. ERCP is generally used only if a therapeutic procedure like stone extraction is combined.
Right. When it comes to treatment, it's primarily medical in the first instance, focusing on managing the consequences of the disease. Pain management is absolutely critical and often very challenging. It typically follows the WHO analgesic ladder, starting with non-opioids, often needing to progress to weak or strong opioids. Referral to a specialized pain clinic is often necessary for patients with intractable pain.
And managing the insufficiency.
Yes, lifelong insulin therapy is required for the diabetes. Pancreatic enzyme replacement therapy, Taking capsules containing digestive enzymes with meals is essential to manage the exocrine insufficiency, improve digestion and absorption, reducing steatorrhea, and address the malnutrition. Comprehensive nutritional support is vital.
When is surgical intervention considered in tropical chronic pancreatitis?
Surgery is indicated primarily for one main reason: intractable, severe abdominal pain that has not responded adequately to all other methods of medical pain relief, including high-dose opioids and pain clinic interventions. The indication is strongest when the pain is clearly associated with large stones obstructing a significantly dilated main pancreatic duct.
What's the surgical procedure of choice in that specific situation?
The standard and preferred procedure described is drainage of the pancreatic duct. This typically involves removing the accessible stones from the main pancreatic duct and then performing a side-to-side pancreaticojejunostomy, usually to a Roux-en loop of jejunum, like a Plaistow or Partington-Rochelle procedure. This operation creates a long, wide connection between the dilated, opened pancreatic duct containing the stones and a loop of small intestine.
The goal being to allow free drainage.
Exactly. It allows the pancreatic juice to drain freely into the gut, thereby decompressing the obstructed duct system, which is thought to be the main source of pain. Pancreatic resection, actually removing a part of the pancreas, like a Whipple procedure or distal pancreatectomy, is rarely considered for pain relief in these patients.
Why is resection avoided if possible?
Mainly because these patients are often young, they already have significant underlying pancreatic damage and insufficiency, which resection would worsen, and resection carries higher morbidity and mortality risks. So resection is generally reserved only as a very last resort for intractable pain when drainage procedures have failed or are not technically feasible.
Okay, treatment summary from the source box. Treatment is mainly medical, managing pain, providing insulin for diabetes, giving enzyme supplements for malnutrition. Surgery is indicated for intractable pain only after all other methods have been exhausted. The main operations are drainage procedures like side-to-side pancreaticojejunostomy to decompress the duct-removed stones. Resection is considered only in extreme cases as a last resort.
So, for mastering this condition surgically, understanding that it's a unique form of chronic pancreatitis, clearly linked to diet and malnutrition in specific regions and not alcohol, is fundamental. Recognizing the characteristic large intraductal stones as a key feature and being aware of that significantly increased risk of pancreatic cancer are also critical points. And from a treatment perspective, knowing that surgery is reserved for intractable pain and that the specific procedure of choice is usually a drainage operation, the pancreaticojejunostomy, designed to relieve pain by decompressing the stone-filled duct, is vital for appreciating the standard surgical approach to this challenging condition.
Very clear. Okay, let's turn now to a major global health issue, an infection with really significant surgical implications in many parts of the world, tuberculosis or TB.
Yes, tuberculosis, caused by Mycobacterium tuberculosis. It remains incredibly common in many tropical regions. But as the source notes, its incidence has also increased again in many non-endemic areas due to factors like international travel, migration, and crucially, the HIV epidemic, which severely compromises immunity. While TB can affect almost any organ system, the source specifically highlights two manifestations that surgeons, particularly those working in the tropical world, most frequently encounter: tuberculous cervical lymphadenitis, TB affecting neck lymph nodes, and tuberculosis of the small intestine.
Okay, let's start with tuberculous cervical lymphadenitis, also known sometimes as scrofula.
Right. This is described as a very common presentation of extrapulmonary TB, particularly in places like the Indian subcontinent. The clinical parole mentioned is that in a young person presenting with enlarged lymph nodes in the neck, especially if they are from an endemic area, tuberculous lymphadenitis should be considered the primary diagnosis until proven otherwise. It's also seen with increasing frequency in indigenous populations with AIDS in Western countries.
Which lymph nodes in the neck are typically involved?
Really, any group of cervical lymph nodes can be affected. Commonly involved groups include the jugulogastric nodes at the angle of the jaw, submandibular nodes, supraclavicular nodes above the collarbone, or nodes in the posterior triangle of the neck. Patients might have some general symptoms of TB, like a low-grade evening fever, pyrexia, perhaps a chronic cough suggesting underlying pulmonary TB, or general malaise. In children, it can be a cause of failure to thrive.
And what are the local findings in the neck that a surgeon would look for?
Initially, just regional lymphadenopathy and large nodes. Characteristically, these nodes often become matted together, forming a firm or rubbery cluster. A distinctive late manifestation, if it progresses, is the formation of a cold abscess.
A cold abscess, meaning it lacks the typical signs of acute inflammation like warmth, redness, and severe pain.
Exactly. It typically presents as a relatively painless, fluctuant, fluid-filled swelling overlying the matted lymph nodes. This indicates that the underlying nodes have undergone caseation necrosis, a type of cheesy, necrotic degeneration characteristic of TB.
What happens if that cold abscess isn't treated?
If left untreated, it can track along tissue planes and sometimes burst through the deep fascia surrounding the muscles, potentially creating a bilocular mass where fluid connects between a deeper collection and a more superficial one. This is sometimes called a collar stud abscess due to its shape. Eventually, the abscess may point towards the skin and rupture externally, forming a chronic tuberculous sinus. This typically has a watery or thin, purulent discharge and characteristic undermined edges, where the skin edge isn't adherent to the underlying granulation tissue. These sinuses can persist and lead to ulceration. The source notes that the tubercle bacilli can destroy subcutaneous tissue relatively quickly and seem to thrive in the less oxygenated environment within the abscess and sinus tract.
How do we investigate suspected tuberculous lymphadenitis in the neck?
General investigations looking for systemic evidence of TB might include blood tests showing a raised ESR or CRP, and possibly anemia of chronic disease. A Mantoux skin test might be positive, but its significance is limited in endemic areas due to high rates of prior exposure or BCG vaccination. The source mentions that interferon gamma release assays, IGRAs, blood tests like quantiferon TB Gold or TB are increasingly preferred as they are more specific for actual infection, latent or active, and less affected by BCG status. Sputum examination, ZN stain for AFB in culture, is important to rule out or confirm concurrent pulmonary TB, although culture takes several weeks.
What about specific diagnosis from the neck lesion itself?
This is key. Aspiration of the fluid from a cold abscess using a fine needle aspiration cytology or FNAC, is often diagnostic. The aspirate can be sent for microscopy, looking for AFB, culture, which is the gold standard for confirming TB and getting drug sensitivities, and sometimes PCR testing for M. tuberculosis DNA. For early adenitis before abscess formation, an excision biopsy of an entire affected lymph node might be performed for histology, looking for characteristic case-eating granulomas, and culture. It's important to send a portion of the biopsy specimen fresh and unfixed to the lab for culture and alert the lab staff to the suspicion of TB.
Treatment involves a combined medical and surgical approach.
Yes, it's managed jointly by physicians and surgeons. The absolute mainstay of treatment is medical, involving a full course of multi-drug antitubercular chemotherapy, typically rifampicin, isoniazid, pyrazinamide, and ethambutol initially, followed by a longer course of rifampicin and isoniazid. It's also crucial to exclude or manage active TB at other sites, especially the lungs. Surgical intervention is generally reserved for managing complications, such as drainage of large cold abscesses, though simple aspiration is often preferred initially, or occasionally excision of persistent sinuses or very large matted node masses that don't resolve with chemotherapy.
Okay, now let's turn to the other major surgical manifestation discussed, tuberculosis of the small intestine. How does the infection actually reach the bowel?
There are several potential routes mentioned. The most common in adults is probably by swallowing infected sputum from active pulmonary TB. The bacilli get swallowed and then colonize the gut. Another route, historically important and still relevant in some areas, is by drinking infected unpasteurized milk containing the bovine strain of TB, Mycobacterium bovis. Less commonly, TB can spread to the bowel via the bloodstream, hematogenous spread, from a focus of infection elsewhere in the body.
The source describes two main pathological types of intestinal TB, ulcerative and hyperplastic. Can you elaborate on those?
Yes. Both types are typically associated with significant enlargement of the mesenteric lymph nodes draining that segment of bowel. The ulcerative type is thought to occur when the virulence of the TB organism is relatively high compared to the host's immune resistance. The bacilli colonize the lymphoid tissue in the bowel wall, particularly Peyer's patches in the terminal ileum, leading to inflammation, necrosis, and the formation of characteristic ulcers. These ulcers are typically transverse-oriented circumferentially around the bowel lumen and often have undermined edges. The outer surface of the bowel, the serosa, might be studded with small, visible tubercles. Histologically, you see the classic case-eating granulomas with Langen's giant cells.
And these ulcers can cause complications as they heal.
Exactly. As these transverse ulcers heal, they do so by fibrosis, laying down scar tissue. Because the ulcers are circumferential, the resulting scar tissue contracts and leads to the formation of multiple fibrous strictures, causing significant narrowing of the bowel lumen and eventually leading to intestinal obstruction.
And the hyperplastic type, how is that different?
The hyperplastic type is thought to occur when the host's immune resistance is stronger relative to the virulence of the organism. Here, the predominant pathological reaction is marked chronic inflammation, leading to thickening, hyperplasia, and fibrosis of the bowel wall itself, rather than discrete ulceration. This often affects the terminal ileum and cecum, areas rich in lymphoid follicles, which seem to be the initial focus. This thickened, rigid bowel segment also leads to luminal narrowing and obstruction. Macroscopically, this hyperplastic form, especially when it involves the ileocecal region, can be very difficult to distinguish from Crohn's disease, which is a major diagnostic challenge.
The ileocecal region sounds like a particularly common site for this hyperplastic form.
It is. Ileocecal TB is a classic presentation, often manifesting as a palpable mass in the right iliac fossa and frequently causing symptoms of intestinal obstruction. The extensive fibrosis associated with this form can also lead to significant shortening of the affected bowel segment. This can pull the cecum upwards, sometimes into a subhepatic position under the liver, and characteristically widens the angle between the terminal ileum and the cecum, the ileocecal angle, to greater than 90 degrees. These are features that can sometimes be appreciated on barium studies.
What about other forms like peritoneal TB?
Yes, the source also mentions peritoneal TB where the lining of the abdominal cavity is involved. This can present with ascites, fluid accumulation in the abdomen, which might be localized or generalized. Sometimes it leads to the formation of dense fibrous adhesions that can encase loops of bowel, sometimes referred to as an abdominal cocoon. Involvement of other abdominal organs, particularly the genitourinary tract, can also occur concurrently.
So what are the clinical features? Can it present subtly or acutely as an emergency?
Both are common. The elective presentation is often quite insidious and chronic, with non-specific symptoms developing over weeks or months. These include things like gradual weight loss, chronic low-grade fever, especially evening rises, and night sweats, general malaise, maybe a chronic cough if there's associated pulmonary TB. Abdominal symptoms can be vague, perhaps some discomfort or distension, and often an alteration in bowel habit, typically alternating constipation and diarrhea.
And the emergency presentations?
These are usually due to the complications of the underlying pathology. The most common surgical emergency is acute distal small bowel obstruction, resulting from the progressive narrowing caused by the fibrous strictures, especially those in the terminal ileum. Less commonly, but more dramatically, perforation of a tuberculous ulcer can occur, leading to generalized peritonitis, which is a major surgical emergency requiring immediate intervention.
What might you find on physical examination?
In chronic cases, the patient often appears chronically ill, perhaps emaciated or anemic. The abdomen might feel doughy on palpation, which can be a sign of underlying tuberculous peritonitis with localized ascites or thickened omentum. A firm, fixed mass might be palpable in the right iliac fossa, suggestive of hyperplastic ileocecal TB. Less commonly, but significantly, you might find a fistula in ano. Tuberculous fistulae are often complex, may have multiple external openings, typically have undermined edges, and often produce a thin, watery discharge rather than thick pus. Late presentation is unfortunately common in resource-poor settings, so patients might present in extremis with severe obstruction, marked abdominal distension, tenderness, constipation, and vomiting, which might be bilious initially but can become faculent later on.
You mentioned other systems might be involved, like the GU tract.
Yes, it's important to ask about symptoms suggestive of genitourinary involvement, such as increased frequency of micturition, urgency, or pain on urination. If these are present, specific investigations of the GU tract are warranted. A key clue mentioned in the source is finding sterile pyuria on urine analysis. That is, finding white blood cells in the urine sediment but having no bacterial growth on standard urine culture. This should always raise suspicion for GU-TB. Further investigation might involve urine testing specifically for AFB and culture for M. tuberculosis, and perhaps imaging like an ultrasound or IVU or cystoscopy. Cystoscopy might reveal characteristic changes in advanced GU-TB, like a contracted fibrotic thimble bladder or deformed golf hole uraric orifices due to scarring.
For the emergency abdominal presentations, what are the initial investigations?
Basic blood tests like urea and electrolytes are crucial to assess the degree of dehydration and renal function guiding resuscitation. A plain abdominal X-ray, erect and supine, is essential if intestinal obstruction is suspected. It will typically show dilated loops of small bowel proximal to the obstruction, often with multiple air fluid levels, and may show characteristic mucosal patterns like prominent valvulae conniventes, concertina appearance, in the jejunum, or a relatively featureless appearance in the dilated ileum.
What about specific investigations to confirm intestinal TB itself?
Similar general tests for TB apply as for cervical disease raised inflammatory markers, ESR, CRP, maybe anemia. Sputum testing is important for pulmonary disease. IGRAs are useful, especially for latent or suspected infection. Abdominal ultrasound might show thickened bowel loops, enlarged mesenteric lymph nodes, which might have characteristic calcification or central necrosis, or localized ascites. A chest X-ray is mandatory to look for evidence of active or old pulmonary TB, which is present in a significant proportion of patients with intestinal TB.
What about imaging the bowel directly?
Barium studies, either a traditional barium meal and follow-through or a dedicated small bowel enema, enteroclysis, are often crucial for visualizing the characteristic features. These include identifying the site and length of strictures, often multiple short annular strictures, especially in the ileum, demonstrating the abnormal high subhepatic position of the cecum in ileocecal disease, or showing the narrow terminal ileum entering the cecum at a straightened abnormal angle. Laparoscopy can also be very useful, both for diagnosis and assessment. It allows direct visualization of the peritoneal cavity, where you might see characteristic tubercles studding the serosal surfaces of the bowel and peritoneum, thickened omentum, enlarged caseating mesenteric lymph nodes, evidence of strictures or the high cecum, and ascites, which can be sampled for analysis and culture. Biopsies of tubercles or affected nodes can be taken for histology and culture.
Okay, quick summary of intestinal investigations from the source box. General tests show raised inflammatory markers, anemia, sputum culture may be positive, IFN assays, IGRAs, useful for subclinical infection. Abdominal ultrasound may show localized ascites, nodes, thickened bowel. Chest X-ray essential to check for pulmonary TB. Barium meal follow-through or small bowel enema demonstrates strictures, especially ileum, and features of ileocecal TB, high cecum. GU tract investigations needed if symptoms warrant. Look for sterile pyuria.
Right. And the treatment of intestinal TB, like cervical TB, is fundamentally a combined physician and surgeon effort. Vigorous supportive care, especially for malnourished or acutely ill patients, is mandatory. This includes nutritional support and resuscitation in emergency settings. The cornerstone of treatment, however, is a full course of multi-drug antitubercular chemotherapy, typically using the standard regimens for 6-12 months, depending on the site and severity.
When does surgery become necessary for the bowel pathology itself?
Surgery is indicated primarily for managing the complications of intestinal TB, particularly symptomatic strictures that cause subacute or intermittent obstruction despite adequate medical therapy, or for acute emergencies like complete obstruction or perforation.
What's the approach for symptomatic strictures, electively?
For patients experiencing ongoing obstructive symptoms from strictures after the active infection has been brought under control with chemotherapy, surgery is often needed. The guiding principle, similar to surgery for Crohn's disease, is generally conservative resection, aiming to preserve as much bowel length as possible, especially since multiple strictures are common. The specific operation depends on the location and extent of the strictures. Options mentioned include limited ileocolic resection for localized hyperplastic ileocecal disease, strictureplasty, surgically widening the narrowed segment without removing it for single, short, fibrous strictures, particularly in the ileum, formal bowel resection for multiple strictures that are located close together, or sometimes a right hemicolectomy if there's extensive involvement of the terminal ileum and cecum.
And what about surgery for the acute emergency of complete small bowel obstruction? This sounds very challenging.
It is extremely challenging because these patients are often profoundly ill, malnourished, septic, and physiologically compromised. After aggressive resuscitation to stabilize them as much as possible, emergency laparotomy is required. The goal here is typically the minimum necessary life-saving procedure. Because of the high risk of anastomotic leak and breakdown in the setting of active infection, inflammation, and poor patient condition, the source strongly advises against performing a primary anastomosis, sewing the bowel ends back together immediately in most cases.
So what's preferred instead?
The preferred approach in most emergency settings for obstructed intestinal TB is a resection of the disease segment causing the obstruction. followed by exteriorization of the bowel ends, typically creating a proximal ileostomy, bringing the upstream bowel end out to the skin and either closing the downstream end as a blind stump or bringing it out as a separate mucus fistula. This avoids the risk of an immediate anastomosis failing.
So a staged approach is often necessary.
Yes, exactly. A one-stage resection with primary anastomosis is described as being rarely performed, reserved only for exceptional circumstances where the patient's general condition is surprisingly good and the local bowel conditions are very favorable, minimal inflammation or contamination. After the initial emergency surgery, resection and diversion, the patient receives a full course of anti-tubercular chemotherapy and intensive nutritional support to improve their overall condition and control the infection. Once they have recovered and the disease is deemed quiescent, for example, inflammatory markers have normalized, weight regained, culture is negative, elective surgery can be performed later to restore bowel continuity, for example, by closing the ileostomy and reanastomosing the bowel ends. If an initial bypass procedure was performed for very severe unresectable disease, a definitive elective resection, like a right hemicolectomy, might be needed later to remove the disease segment or blind loop. Any other significant strictures identified could potentially be addressed with strictureplasty or further resection at this second stage.
What about the management of perforation?
Perforation of a tuberculous ulcer is another major surgical emergency. Again, vigorous resuscitation is the first step. This is followed by laparotomy with resection of the affected bowel segment containing the perforation. Whether a primary anastomosis can be safely performed depends heavily on the conditions found at surgery. If the contamination is minimal and the surrounding bowel appears healthy, it might be considered. However, more commonly, especially with significant peritonitis or widespread disease, it's safer to perform the resection and exteriorize the bowel ends as an ileostomy, stage 1, with restoration of bowel continuity planned for a later stage, stage 2, after the patient has recovered from the sepsis, completed a course of chemotherapy, and their nutritional status is improved.
Okay, final treatment summary from the source box. Requires combined physician-surgeon management. Vigorous supportive care and mandatory full anti-tubercular drug treatment are essential. Symptomatic strictures causing subacute obstruction are managed by appropriate elective resection or strictureplasty once the active disease is controlled medically. Acute obstruction requires resuscitation, followed by surgery, typically resection with ileostomy, or rarely primary anastomosis if conditions are ideal. Perforation requires resuscitation, resection, and either primary anastomosis if safe, or more commonly, ileostomy with planned later restoration of continuity.
Right. So, for surgical mastery of TB, recognizing that it's far more than just a lung disease and understanding its potential to cause specific severe surgical pathologies in lymph nodes, like cold abscesses and sinuses, and particularly in the bowel, ulcers, strictures causing obstruction, hyperplastic masses mimicking Crohn's or cancer, and perforation is absolutely essential. Grasping the different pathological forms in the intestine, and critically, understanding the challenging surgical management principles for acute complications, especially that strong preference for staged procedures involving diversion, like ileostomy, in critically ill, malnourished patients to avoid the potentially lethal consequences of anastomotic leaks, are really key pieces of expert knowledge derived from this source material.
Extremely important points.
Yeah.
Okay, finally, let's discuss typhoid fever. This is an infection usually managed by physicians, but it has a potentially devastating surgical complication that every general surgeon absolutely needs to recognize and know how to manage.
Yes, typhoid fever, caused by the gram-negative bacterium Salmonella typhi, and related species causing paratyphoid fever. Like many of the infections we've covered, it's primarily spread through poor hygiene and sanitation, typically via ingestion of contaminated food or water. While the systemic febrile illness itself is firmly in the domain of physicians or infectious disease specialists, the surgeon's role is usually called upon urgently when specific complications arise, most notably perforation of the bowel.
And the pathology underlying these complications primarily affects the Peyer's patches in the small intestine, correct?
Precisely. After being ingested, Salmonella typhi has a particular affinity for colonizing the lymphoid tissue within the Peyer's patches, which are most abundant in the terminal ileum. The infection leads to inflammation and marked lymphoid hyperplasia within these patches, followed by necrosis and ulceration. Histologically, you might see features like erythrophagocytosis, macrophages engulfing red blood cells, and proliferation of histiocytes within the affected lymphoid tissue.
And these ulcers are the source of the surgical problems.
Exactly. If the systemic illness is untreated or inadequately treated, these ulcers in the Peyer's patches can deepen and eventually penetrate through the full thickness of the bowel wall, resulting in perforation and spillage of bowel contents into the peritoneal cavity. Alternatively, the ulceration can erode into underlying blood vessels, causing significant gastrointestinal bleeding, which might manifest as melena or even brisk hematochezia. While the terminal ileum is by far the commonest site for these complications due to the concentration of Peyer's patches there, the source notes that perforation can occasionally occur at multiple sites, or sometimes even involve the large bowel, although that's much less frequent.
How does a patient with a perforated typhoid ulcer typically present? What's the classic clinical scenario?
The classic scenario described is a patient, often from or having recently visited an endemic area, who has already been significantly unwell with a persistent high fever for about 2 to 3 weeks. They are usually systemically toxic, perhaps confused or delirious, typhoid encephalopathy. They might have abdominal distension due to the paralytic ileus that often accompanies severe typhoid. They may also have had recent melena suggesting bleeding from the ulcers, potentially contributing to hypovolemia.
And then the perforation happens.
Yes. If, typically after the second week of this ongoing illness, the patient suddenly develops severe generalized abdominal pain, the diagnosis of a perforated typhoid ulcer must be very strongly suspected until proven otherwise. Their condition, already compromised by the prolonged typhoid illness, will usually deteriorate rapidly, and they will develop the classical clinical features of generalized peritonitis, a rigid, tender abdomen, guarding, rebound tenderness, and absent bowel sounds.
What's the crucial radiological sign we look for to confirm perforation?
Free gas under the diaphragm in the peritoneal cavity. This is best demonstrated on an erect chest x-ray. If the patient is too ill to stand, a lateral decubitus abdominal x-ray, with the patient lying on their side, can show free air collecting over the liver or under the lateral abdominal wall. Any patient who is already being treated for typhoid fever and experiences a sudden clinical deterioration accompanied by new or worsening abdominal signs should be urgently investigated for perforation with plain radiographs.
Okay, perforation diagnosis summary from the source box. Patient typically from or recently visited an endemic area. Has had persistent high temperature for 2-3 weeks and is very toxic. May have positive blood stool cultures and already be receiving treatment for typhoid. Signs of peritonitis developing, usually after the second week of illness, strongly suggest perforation. This is confirmed by demonstrating free gas on plain radiograph, erect chest x-ray, or decubitus view.
Right. And the management is a true surgical emergency requiring immediate admission, ideally to an intensive care setting, for aggressive resuscitation and stabilization before surgery. This includes vigorous intravenous fluid replacement to correct dehydration, electrolyte imbalances, and septic shock. Broad-spectrum intravenous antibiotics are crucial, needing to cover Salmonella typhi itself, but also the likely polymicrobial contamination from the bowel perforation. So, often including cover for gram-negatives and anaerobes, drugs like third-generation cephalosporins, gentamicin, metronidazole are mentioned, along with chloramphenicol historically, though with caution due to its potential for causing aplastic anemia.
And then prompt surgery is essential.
Absolutely. Once the patient is resuscitated as much as possible, emergency laparotomy is required. The specific surgical procedure performed at laparotomy depends heavily on several factors assessed intraoperatively. The patient's overall physiological condition, the exact site and number of perforations found, the health of the surrounding bowel tissue, and the degree of peritoneal contamination, soiling. The source outlines several potential surgical options.
What are those surgical alternatives?
Options range from relatively simple to more complex. For a single, small perforation in otherwise healthy-looking bowel, simple primary closure of the perforation, often after freshening the edges, might be possible. Sometimes a wedge resection excising the small segment containing the ulcerated Peyer's patch followed by primary closure is performed. For multiple perforations, larger defects, or if the surrounding bowel appears ischemic or unhealthy, then formal bowel resection of the affected segment is necessary.
And after resection. Anastomosis or diversion.
That's the critical decision. Primary anastomosis, joining the bowel ends back together immediately, might be considered if conditions are optimal good patient condition, minimal contamination, healthy bowel ends. However, given that these patients are often severely ill and septic, exteriorization of the bowel ends is frequently the safer option. This means bringing the proximal end out as an ileostomy and dealing with the distal end either by closing it, Hartmann's procedure, or bringing it out as a separate mucous fistula. The source also mentions another historical alternative, closing the perforations and performing a side-to-side iliotransverse anastomosis to bypass the affected terminal ileum, although this creates a blind loop which can have its own long-term problems.
The source gives a really critical instruction about thoroughly checking the rest of the bowel during the operation.
Absolutely vital and a key point for surgical mastery here. After dealing with the obvious primary perforation in the terminal ileum, it is mandatory to meticulously examine the entire length of the small and large bowel. Why? Because synchronous perforations can occur, or there might be other areas of deep ulceration or necrosis that look like they are about to perforate. Any such suspicious areas must be dealt with appropriately at the same time, either by overseeing them, closing them, or including them in the resection. Thorough peritoneal lavage, washing out the abdominal cavity with copious amounts of warm saline, is also absolutely essential to reduce the bacterial load from the fecal spillage.
And postoperative wound management sounds like it needs special consideration too.
Yes, wound infection and complete wound dehiscence breakdown are noted as being common complications after surgery for typhoid perforation. This is due to the combination of heavy contamination, the patient's poor nutritional status, and underlying sepsis. Therefore, the source recommends a strategy often used in contaminated abdominal surgery. Closing the deep layers, like the peritoneum and maybe the fasciolinia alba, but leaving the superficial layers, subcutaneous tissue and skin, open. This allows the wound to drain freely and can be managed with dressings, potentially followed by delayed primary closure or secondary closure, once the risk of infection has subsided. Laparostomy, deliberately leaving the abdominal fascia open, often covered with a temporary closure device, is also mentioned as a good alternative management strategy in cases of very severe, rampant intra-abdominal infection and sepsis.
Prognosis seems to be linked to the timing of perforation and intervention.
Yes. The source notes that, perhaps counterintuitively, the prognosis is generally better if the perforation occurs earlier in the course of the illness, for example, in the first week, compared to later, second or third week. This is likely because the patient's overall physiological condition and immune defenses are usually stronger earlier on, before being depleted by prolonged fever and toxicity. Unsurprisingly, a shorter time interval between the clinical diagnosis of perforation and the actual surgical intervention also significantly improves outcomes. Prompt recognition and rapid treatment are key.
Okay, final perforation treatment summary from the source box. Managed aggressively in an intensive care setting. Requires vigorous resuscitation and broad-spectrum IV antibiotics. Emergency laparotomy is necessary, with various surgical options depending on the intraoperative findings. Simple closure, wedge resection, formal resection, plus stasia anastomosis or exteriorization. Terminal ileum is the common site. Always inspect the entire bowel meticulously for other perforations or necrotic patches. In very ill patients, consider exteriorization, ileostomy. Close deep layers, but often leave the superficial wound open for delayed or secondary closure.
Exactly. So for surgical mastery of typhoid fever, the absolute key is recognizing that this relatively common systemic infectious disease carries the potential for a specific life-threatening surgical emergency, namely bowel perforation, which typically occurs later in the illness, after the second week. Understanding that classic clinical presentation in a toxic patient, often with a relevant travel history, knowing to look for free gas on X-ray as a diagnostic sign, and being skilled in the various surgical strategies for managing the perforation itself, particularly that critical decision-making between primary repair resection and the often safer option of exteriorization based on the patient's condition and the degree of contamination, aiming to avoid catastrophic anastomotic leaks. These are the essential skills and knowledge points derived from our source text.
Wow. What an absolutely incredible, and I have to say, quite intense deep dive into these diverse and truly challenging tropical infections and infestations. We've really journeyed across a wide landscape today, from parasites causing insidious liver masses or crippling lymphatic swelling, all the way to bacterial infections leading to devastating bowel complications or nerve damage requiring incredibly complex reconstruction.
It's been quite a tour, and by really dissecting each condition, trying to understand the underlying pathology, recognize the often subtle or frankly deceptive clinical signs, master the appropriate investigations, and really grasp the specific, sometimes very complex surgical management strategies laid out in our source text, we've genuinely aimed to provide you, the listener, with a foundation of knowledge. A foundation perhaps akin to that held by the elite professionals who regularly tackle these demanding conditions in their practice.
Absolutely. And a powerful thing that emerged again and again throughout this deep dive, one strongly emphasized in the source material, was the absolutely indispensable need for a multidisciplinary approach. These clearly aren't conditions that can or should be managed in silos.
Not at all. Physicians, surgeons from various subspecialties, general, plastics, orthopedics, hepatobiliary, radiologists, pathologists, microbiologists, infectious disease specialists, physiotherapists, they all need to collaborate closely. And the source implicitly and sometimes explicitly suggests there should be no hesitation in seeking help from or referring patients to specialist centers when faced with these difficult, sometimes unfamiliar, and often complex diagnoses.
It really speaks volumes about the complexity of the sheer variability of these diseases, doesn't it? And the collective expertise that's really needed to achieve the best possible patient outcomes.
Yep.
And as we kind of circle back to where we started this discussion, the inescapable reality is that with the incredible ease of international travel today and ever-increasing global movement of populations, these conditions are simply no longer strictly confined to specific geographic regions anymore. They are undeniably part of the global landscape of surgical disease.
Which means they could potentially appear in almost any hospital anywhere in the world.
Exactly, which underscores precisely why mastering this knowledge, really understanding these seemingly tropical infections and infestations from a surgical perspective, is becoming increasingly relevant and frankly necessary for surgical professionals everywhere, regardless of where they practice.
That global health context is impossible to ignore now.
For sure. So here's a final thought to perhaps leave you with, something to mull over that builds on everything we've covered today. Given this interconnectedness of global health, how might broader factors like climate change, which we know is altering the distribution of disease vectors like mosquitoes, or perhaps major geopolitical events driving migration, continue to reshape the map of surgical diseases that we might encounter in our daily practice in the coming years and decades?
That's a huge question.
It is. And maybe relatedly, reflecting on how often factors like socioeconomic status, poverty, and basic sanitation were mentioned as underlying contributors to the burden of many of these diseases. What broader role does public health, infrastructure development, and perhaps fundamentally addressing global inequities play in ultimately reducing the need for complex surgical interventions for these conditions worldwide?
Very complex questions indeed, with likely even more complex answers. But certainly critical issues to consider as we think about the future of global surgery.
Indeed they are. It's a vast and incredibly important topic. Thank you so much for joining us on this very deep dive into tropical infections and infestations from a surgical perspective.
Keep that curiosity alive, keep exploring, and keep learning.